work that we're going to do over the next year. So the context for this is that it's the start of a stream of the Mental Health Policy Research Unit's work, which is going to support the work of NHS England and the Department of Health, aiming to find better ways of addressing the needs of people who've in the past received a diagnosis of personality disorder. And Viral is going to tell you more about that from an NHS England point of view. But basically, the aim, hopefully, is that this is a pathway to greater investment and to strategies for improving services. So hopefully this is the beginning of taking things in a positive direction. But more than with most topics, it's actually quite hard to begin the discussion, as it's not even clear how best to describe the problems that we're talking about. So we want to talk about services that most often have been called community personality disorder services, and have focused on people who've been given labels like emotionally unstable or borderline personality disorder. However, as most of you are aware, these descriptions have become quite tarnished by remarkably high levels of stigma attached to them, by a lack of therapeutic optimism, and by doubts about whether this really is the right way of identifying a group of people who, for the most part, have experienced quite severe trauma, often in childhood. So we are going to talk, we hope, today about these very tricky issues of terminology, although obviously with things like diagnostic classifications, there are limits to what we would be able to do about them. But we hope also that we'll move on beyond that and talk about the most interesting questions, which are about what people who are served by these, or served or often not served at the moment by these kind of services, what they actually need, what they feel they would like from services, and what sorts of models of care might actually begin to address people's needs. So those are the questions that we're most going to focus on in our work, and those are the things that we hope to have some preliminary help from you in terms of pointing us in the right directions. So our further work will involve looking at literature and talking to people with direct experience of services, initially to try and identify the kind of range of approaches and models that there are. We'll then go on, when we've got a sort of good sense of what, in particularly of innovative good practice in this area, of the kinds of approaches that have been taken, we'll go on to talk to service users around the country, clinicians and carers, and friends and relatives, to try and understand what they think of these models and what they feel might be a good fit. And at the same time, Paul McCrone and his health economic team will be doing some cost effectiveness work. And the aim of that, above all, is to try and build a case for investment in whatever look like the best models for these kinds of services. So that's the background. We've got a great mix of people in the room who hopefully can help us tackle this from a variety of directions. As I say, this is the beginning rather than the end of our work in the area, and also the beginning and not the end of consulting people about it. So we're here to kind of explore and discuss the issues more than to come to any kind of firm final conclusions about them. And I expect we'll be able to have a very open and constructive discussion about the various points of view. We hope also, we had a bit of debate about whether to just keep this as a sort of small initial meeting to give us guidance in which direction to go, or whether to also try and engage with the public. We decided we should try and engage with people beyond this room from the beginning. So we do encourage you to, if you're so inclined, to tweet, to talk to people, to engage with people who may be talking to people. And several of the talks are going to be live streamed, so people will be able to watch from elsewhere today and will also be able to watch and engage afterwards. So hopefully this will be the beginning of a continuing public discussion as well as the discussions that are going to happen today in this room. Okay, so thank you and welcome.
Lovely, thank you, Sonia. So without further ado, can I invite Viral? That's terrible, isn't it? Oh, clicker, yes. So you've got one hand for clicker, one hand for Mike, who's a consultant clinical psychologist and also an activist. And obviously is going to be setting the scene from a slightly different perspective.
Hello. It's kind of like a big task, so I have to, well, I can't not be passionate, but also hold the microphone and do this, so let's hope it works. Can I just start off with a trigger warning, perhaps especially for people at home. I'm going to talk about some quite difficult things, and obviously self-care is always number one. There is one slide that I'll alert you to, and if you cannot retweet it without doing trigger warning at the top for people. So, should we bow to the science? My talk really is about thinking about language that we're talking about. Should we bow to the science? Now, if we look at the construct of personality disorder, we haven't got time to go into it at depth, but we know it's got a history that comes from the psychoanalytic movement, and we know it originally comes from characterological types that were used in a way as a kind of fast track, and those obviously linked with the societal ideals of the time, and that's going to be something I'm going to be talking a bit more about. We look at when they emerged, we have a kind of sort of archetypes, like he is a grandiose narcissist focused on immediate gratification and a feared, increasingly self-centric post-war environment. And she hasn't taken enough Valium and is kicking off and not being a very good housewife. So there is a kind of sort of etiology there. And really since then, in terms of psychiatric nosology, there have been desperate attempts to get away from what Spitzer and actually everyone who's led all the diagnostic Bibles, i.e. the DSM and ICD, have said since, which is a kind of embarrassment about the construct validity around PD. Now, in terms of that, we can perhaps take a quote as a shortcut from Peter Tara, who, of course, many of you will know, is the chair of ICD-11, i.e. literally, you know, what we are going to do next across Europe. And Peter said, why retain the word personality, given the lead of the design committee, oh, sorry, I'm reading my own things, you can tell I'm a bit nervous. I only state that borderline personality disorder has far greater affinity to mood than to personality. Its core is not a disorder of depression or mania, but one of emotional dysregulation associated with many other mood states. Nothing about it is driven by personality. The very name, borderline personality disorder, betrays an abrogation of diagnosis. And that's an argument that Peter has reiterated in a book that he had out last year. So we can have as our kind of starter for 10, that if literally the person in charge is going, well, actually scientifically wise, you know, the word personality doesn't fit, I think that can give us bagginess in terms of our thinking about what services that are desperately needed that are open and inclusive might look like. Now, in terms of the construct validity, we've already touched on, and I hope we're touched throughout the day, that we are not talking about a homogenous group. And that, in a way, has been a great blocker to change, because what happens is people go, oh, what about complex PTSD? And then people go, oh, wait a sec, I know so-and-so who doesn't have trauma, and then the system reverts back to what it knows. Now, in terms of that, always, in terms of the etiology of why things become difficult in life, the N is always 1. Having said that, we know if you take literally one of the most conventional biological or epidemiological PD people, i.e. Joel Paris wrote the handbook of PD, he talks about how adverse experiences, adverse childhood experiences are there for 2/3 of people. So we know we are talking in terms of the majority, not just about a population that's 3/4 women, but that a population that has traumatic experiences and that actively has been telling us for 50, 60 years, again and again, that there is re-traumatising in terms of being told that one's very personality is disordered. Apart from that, of course, we know there is this blurry, bloody line with psychothalemia. That's been going on as a debate for decades, really. But I think increasingly there is, as people know, a real movement in terms of thinking about other pathways as well, whereby interactional things can be bloody difficult. Now, one of those is in terms of thinking about Asperger's and autism, and people will know that there is a massive, massive movement at the moment, really to think about what a female sort of phenotype will be for those kind of difficulties. The latest figure is that people think there are 200,000 people in the UK who haven't had a diagnosis and actually might find something like that more useful. When we're thinking a little bit later about our service provision, we have to think very, very importantly then about the ethics of having behavioural contingency management that is based on trying to get people into kind of normative relations. When, of course, as people know from the ASPE movement, from the social model of disability, etc., actually it's precisely being sort of squeezed into those kind of boxes that actually kind of cause loads of problems. Also, of course, we have the pathway of misogyny and heteronormativity. The wonderful Rachel is going to be speaking about that a little bit later. We know just very, very simply, as I haven't got much time, take the LGBTQ population. We know that there is massive increased rates of self-harm. We also know with that if one is in a society that doesn't validate you, that actually what do people do? Well, they try and assimilate to the host culture. They push the host culture away, and that gets embodied on the body, that gets embodied on the psyche. And we really need to think about that in terms of a society that increasingly recognises difference, and think about that in terms of the models that we are talking about. Now, in a way, the only key thing to all this is that the environment is absolutely crucial. A validating environment, absolutely crucial. Very, very simple here. We've got the tronic still face experiment on the left in terms of thinking about attachment. The environment and interactional patterns early on are so powerful that if you do the still face experiment, where basically you have mother, you have caregiver who doesn't act in an attuned way, we have 80 or 90 studies and a new wave of studies going that actually a 4-month baby physiologically in terms of stress markers will keep that memory in their body. So in terms of that, when we're thinking about attachment difficulties, environment crucial. ACEs really coming through to prominence, so the adverse childhood experiences, really so crucial to link that in with trauma-informed care. And especially important with that, we've got an expansion coming through in the States at the moment of not just thinking about adverse childhood experiences, but adverse community experiences. And that includes much more different types of oppression that, again, as we know, people have to try and make sense of. We in services have to have space where we actually validate difference and we validate lifetime experiences. And that links with the box on the right, which is whereby we know that many, many of the difficulties derive from an invalidating environment where, for example, one is growing up lesbian or gay in an environment where, you know, one is kind of constantly presented with a heteronormative ideal. And actually, you know, trying to come to terms with that is incredibly bloody difficult. If we then have services that reinforce, even not explicitly, but implicitly in our model, a heteronormative ideal, we seriously fail people, and I know we're all committed to not doing that. So, in terms of that, if the environment is absolutely crucial, what could be more important than listening to what survivors tell us about their experience of the environment that is mental health services? And we know that people have been telling us, again, 40, 50, 55 years, we have the data on this, then actually it is of invalidation, and actually worse than that, it's actually re-traumatising. So here is a quote from a member of the PD, the brilliant survivor-led organisation Personality Disorder in the Bin. Being diagnosed with borderline personality disorder as a teenager only prevented me from getting the help I needed to recover from the experiences of childhood abuse. And worse, still it actually caused harm by reinforcing the controlling behaviour and lies which the perpetrator of my childhood abuse had used to prevent me from escaping the abuse or reporting him, making me believe, and this is what we hear all again, it was all my fault, and increasing the self-harm and self-blame and self-harm. And we know with that there are so much biases within the system. There's an example below of diagnostic overshadowing, i.e. we know the idea of a disordered personality is so silencing that we have people going, say, to GPs again and again, to A&E with all sorts of problems, and actually it doesn't get heard because it's all seen within the frame of being manipulative and attention-seeking. Someone quite dear to me ended up in ICU because of that last year. So, in terms of that, we have, as already been alluded to, 2003, personality disorder, no longer a diagnosis of exclusion. It didn't bloody work. Let's do something different. It's so exciting if we can do that. Linked with that, I just want to see very quickly, because I do quite a lot of feminist work, this is the women's mental health into the mainstream, and that's back from 2002. If you speak to the leads on the movement to have decent women's mental health in mental health, what people say who are literally writing the DOH reports, they say the concept of personality disorder has been a blocker. So it's actually been obscurating the change that I'm sure we would all agree on that comes through in documents like that from 2002, which is why we've had to have nearly the same report on wanting things like women's only crisis house, etc. last year. Now, in terms of that, Sue, we've got Sue here, which is marvellous. We know that pretty much everyone, now I'm not going to say everyone, and I know I'll probably make some enemies here, but pretty much everyone agrees the label has to go. So we have on the left the consensus statement that we're going to hear earlier. On the right, we have PD in the bin, going, we reject the pathologisation of our way of being in the world. We find the PD label dehumanising, and it encourages a system and society that seeks to blame us for our own reactions. Now, the evidence that there is a systemic bias, a structural bias against these people with this diagnosis is absolutely overwhelming. So we know, for example, that if you compare to people who have been given the diagnosis of schizophrenia, mental health staff will act in a far less warm way, so they'll act with a less affectionate involvement. They'll contradict people, they'll reject people. We're going to hear later testimony about how quite explicitly neglectful that rejection can be. We know that people are constantly constructed as things like manipulative. Huge, huge evidence base for that. And we know it's one of the most damaging things. This is the tweet whereby if you take a photo of it or retweet it, please do a trigger warning. So this was sent to me by a survivor activist who wanted it to be used, or wants it to be used, to make things better. So what we have here is a letter from one GP. Now the GP goes, seen, obviously Laura is a made-up name, seen by CPN, so seen by the psychiatric nurse on Monday, no marks around the neck, so no physical signs of a ligature wound. CPN agrees with my take here that Laura has seen another doctor in the surgery, is an empathic individual, and played to this in saying this. The feeling from the CPN is this never happened and would reference us to, and then the consultant psychiatrist letter. It's important not to respond to claims as they seem to only worsen Laura's personality disorder presentation. Laura is not someone who is out of control. She's highly controlled and fairly manipulative due to her personality disorder type. She has a proven track record of constantly vocalising suicidal ideation and is very capable of contacting the appropriate people when she feels the need. But the feeling is very much that we don't respond unless physical signs, i.e. one literally needs to have, you know, the rope thing around one's neck, showing that her story is being supported by others. So if we think about that in terms of testimony and justice, we have Laura Laura in the middle of a system. And what we have in terms of that is she forges, there's one person she likes. Now, if you guys tell anyone anything, if someone's warm, you tell them more. I mean, seriously, we do that at the cafe, let alone with something serious. That's okay, yeah? To have someone that one gets on with. But actually what we have in response to that is we have Dr. G, who's a GP, who's the letter writer, and the CPN colluding and using the consultant psychiatrist's letter to basically sever the link between Laura and Dr. T. And actually not just do that, but construct her, position her as highly controlled, fairly manipulative due to her PD, not to be taken seriously unless there are physical signs of her having tried to kill herself, and a real accusation, so we've got the character slur going here, constant association with moral problematicness in some way, that she's accused of constantly vocalising. So we have Laura actively through the ideology of PD that is spread really, really kind of as a sort of wave of knowledge between Dr. G, the CPN, and Dr. X. And we also have Laura being explicitly told by all those three people that when she thinks people are against her, she's being paranoid. And we have all that happen. I mean, imagine the headlines, person goes in, I said, oh, it's just crazy. And we have all that happening within a wider societal discourse. So a second there, which is going, you're not alone. If you're feeling suicidal, please tell someone. So what we're talking about in language is a kind of language that enables what very, very clearly is certainly neglectful and I would say abusive. And we have that admixture of testimonial injustice, so the slurring of someone's capacity to be believed, to be heard. We have the unconscious biases, so, we know most people don't think they're schmucks with talking around PD, yeah? They recognise there's a bit of a bias, but people just don't realise how much they are enacting it. There is what I think of as the PD shield, where there is a kind of sort of like, get the fuck away, you're scary. Now, if you think in terms of attachment, excuse my language, I tried not to swear.
Please do.
Yeah, when you think about, say, attachment isn't always the case, but the last thing you want in producing a validating environment is people who are actively, and we're picking up this stuff, HPA access to HPA access, right brain to right brain the whole time, who are basically going, I can't bear you. It's the worst thing that we can do. Now in terms of that, this is not, as everything I say really from me, survivors have been saying for 50 years the same analogy. And the analogy is with a witch trial. So witch trials, as people will know, is with a witch trial, the only way to prove her innocence is trial by water, dunking her into the lake. If she drowns, she's innocent, but she's dead. A same with this thing that the PD ideology enables. The only way with Laura's case, with multiple people across the country, to prove one's suicidal intent is serious and one's suicidal discourse not being manipulative or attention-seeking is to die. And I actually had to stop tweeting this because it was too triggering, even with a trigger warning. We have week after week after week people, predominantly with trauma histories, always who are struggling, who actually we are driving practically to the coroners because of not listening. This in a wider culture where things like #BelieveHer, that's a hashtag that comes from the Cabana trial, is bigger and bigger. So, oh God, I've got 1 minute. Okay, I just want to make a very, very, very quick point. Now, if you think about things like, this is the STEPS model. At the moment, we have a bit of a paradox, whereby, if we think about things like how we're doing DBT, if we're thinking about things how we're doing like STEPS, we are selling with it an ideology that is absolutely unnecessary. And we are doing it more actively, and I think about this constantly, but I think about this all the time when I'm not thinking about tea, in terms of selling this ideology and using belief in it as the only way to access services in a way that we don't do with the diagnosis of schizophrenia, say. Thinking about my CBT for psychosis training, thinking about family intervention for psychosis training, you would not pass in terms of adherence if you didn't get treatment unless you accepted, same with clozapine, unless you accepted the idea of schizophrenia. It would not happen. You would literally, even the most biological person. And yet, we have, say, with steps, with DBT, especially when it's done, you know, we tend to have pre-commitment sessions where all you've got in a trust is DBT, and you have to go to 4 sessions where you basically have to accept and swallow in an ideology that we know for a substantial amount of service users is a character assassination. And if people don't go along with that, they get nothing. We cannot have that. I'm sorry, whatever our individual beliefs are, if we're doing an ethical system. And so I've got a thing going to stop, I'm going to pretend I can't read, I'm going to take 30 seconds more. And so with steps, we have this active socialisation. So literally what happens in the first session of steps, you know, you get given a printed handout listing the DSM-4 criteria, because you have to own the disorder first. You have to kind of sort of accept, and this is especially problematic, we have to think about this in terms of trauma-informed care. There is a constant dialogue that identifying someone to blame for the disorder is usually counterproductive. How can we do that when 2/3 of people have had adverse childhood experiences? If you look at things like STEP and DBT, if you look at the actual components, we're talking about life skills, and we're talking about, you know, we all know how it rolls. Like, a lot of it's nicked from mindfulness, a bit from, you know, and then someone packages it. So we can offer things that are useful in a way that doesn't force feed people and thus make sure some people get nothing and die. We can do that, we can commit to that. I'm going to stop there, thank you so much.
Okay, thank you, Jade. Can I ask Mike Crawford up? Let's have a wand and a clicker. Let's see if we can find you on here. And we're running woefully over time already, so I've completely failed miserably. Where am I here before? There we are. Okay, Mike, over to you. Thank you.
Okay, well, thank you, Chair. I was interested and very taken by your presentation, but there's going to be a lot of things I'm going to say which won't concord with what you were saying. But I think that's partly the way the day's been set up, really, to kind of have a discussion. But I think some things have been juxtaposed in a way which I hope we can get beyond when maybe we have some of the discussions later on, because I think we could end up with a kind of false dichotomy here where people who are all working towards trying to help people who have problems associated with personality could end up arguing rather than thinking about a constructive way forward. What I wanted to do was focus on services for people with a diagnosis of personality disorder that's currently configured, and think about what's a problem with that in some ways that might help, particularly around the concept of stepped care approach, which is being used increasingly in areas like depression and other mental health conditions, and I think may have some traction for using better use of resources for people with these problems. I did want to say a little bit about the terminology, because I know that's part of the theme of the day, but I think there is a danger that we spend too long thinking about the labels that we're using, because we need to think about the needs of patients who have these difficulties. And this is an illustration of the difficulties of someone with a diagnosis of personality disorder, taken from that report we were hearing about in 2002. And it talks about the dreadful start in life that an individual has, which will be familiar to people working in mental health services. But the bit that I would focus on is the experience of living with these difficulties, the emotional distress, of waking up every day feeling empty and dead inside, of not being sure whether you want to live or die. And it's not just the emotional distress which makes personality disorder such a significant problem. We know that the quality of life of people who have a diagnosis of personality disorder is often less, it's often lower than those who have a diagnosis of psychosis. Social functioning is often greatly affected, leading to unemployment and difficulties in completing social roles. And we have a rate of suicide which is 50 times that of the general adult population. There's been a lot of good work looking at the physical health needs of people with psychosis, because diagnostic overshadowing is not specific to personality disorder, but we know that the life expectancy of people who have these difficulties is equally reduced as it is in people with psychosis, but something which is not very often discussed. These difficulties are also really important because they're not uncommon, and reference was already made to the fact that using the current diagnostic system, the prevalence of personality problems is greater than that of psychosis. But if we compare the services that are available to people with personality problems, they are very poor compared to those that are available for people with other severe mental disorders. And we have, we're not going to talk too much about inpatient care, but we spend a huge amount of money every year on people with these difficulties having long-term admissions to hospital, and that is often because there is a lack of availability of effective community services. You know, we will be talking more, is this a diagnostic term we want to refer to or not? And obviously the day has been set up with the support of NHS England, and NHS England uses the phrase personality disorder all the time. You know, we've had nice guidelines for over 10 years. Personality disorder is in the 5-year forward view. It's explicitly mentioned in the NHS long-term plan, particularly around the needs of women in the perinatal period. And NHS England have just commissioned an international group to look at outcome measures for people with these difficulties. So whatever the limitations of the label, it's a label which is embedded within policy, clinical practice, training and education of our mental health workforce. I agree with a good portion of what Jay was saying earlier on. I think, I can't remember the phrase you said, you know, what really matters is an N of 1. If you want to engage someone in something which is going to be effective and supportive for them, of course, you will want to think about the needs of that individual. And any label is pretty rubbish. And all our mental health labels aren't that good. I don't think the name schizophrenia is particularly good, and I've met a lot of patients who don't feel very helped by getting that label. I've met people who've got emotionally unstable personality disorder who feel helped and not helped by the label. But what I totally agree with is that we need individualized level consideration of a person's difficulties and formulation of a person's problems and what might be helpful for them. So whilst the label personality disorder is pretty useless if you're a patient, I believe it's vital if you're involved in the planning or delivery of mental health services. And the main reason for that is that if you don't get a label of something like personality disorder, you will get given another label. And that's what happens currently in mental health services. Many people who have long-term severe emotional distress are mistreated. We know in the UK that over half of people with this diagnosis are taking long-term antipsychotic medication despite no evidence that that's helpful. A quarter of people are taking mood stabilizers, and that, we know, is not helpful. Not only do we give treatments that don't work and make patients feel worse because they're not responding to something you're never going to respond to, we also fail to give treatments that do work. Dialectical behaviour therapy, day therapy community treatment models, these day-based psychological therapy programs, we have a solid evidence base that these treatments are effective, but what we have at the moment is a waiting list problem for many services, and we have delays for people accessing services which run into years. You know, NHS are doing great work in early intervention psychosis, getting a treatment plan within 2 weeks of being referred. The gap between coming into contact with mental health services and getting some access to effective evidence-based treatment can be measured in years, certainly not in weeks. But the label is rubbish, and if I was a patient, I wouldn't want the label particularly. So I'm entirely comfortable with the idea of people with a personality disorder diagnosis, because this is a way for services and policymakers to construct their thinking. What we need is case formulation for the individual person. Of course, the only problem with that label is that many people who have these difficulties are being mistreated for bipolar affective disorder, so I think it is important that we do make accurate assessments of people's problems. This is a summary of NICE guidelines from 10 years ago. The bulk of treatment should be within community mental health services. Consider specialist referrals and don't use brief interventions. I'd like to say what I think is a problem with this. Two particular problems. The first is the current quality of care that's delivered by general mental health services, by well-meaning individuals who are more comfortable treating people for depression, bipolar affective disorder, and missing out on the fact that people may have different kinds of problems. This is a very busy slide, but what it shows is that if you can see this kind of dotted area, that means that people are coming into the service and getting no better. Even worse is the black area, the shaded area. That's where people come into the service not having a problem, but leave it with the problem. This relates to personality disorder treatment, this relates to psychosis, and these are data from Westminster, where I work as a clinician. And we were appalled to see that there is evidence that people with personality difficulties are not getting better, and in some instances they seem to be getting worse as a result of their contact with general adult mental health services who aren't recognising the nature of the person's problems. So it's not surprising that really good qualitative research conducted by service users looking at people's experience of community mental health care says people didn't know what to do. People were treating you for conditions they didn't have, and the kind of negative testimonies that we were just hearing about. The second problem is that we have evidence-based effective treatments, but it's very hard for people to access those treatments. And we also have NICE guidelines which say that you shouldn't deliver short-term treatments. Now, I hope when the additional work that's going to take place starts to take place, there's a real look at shorter-term treatments, because I believe that NICE guidelines need to be updated. And some of the concerns that were around short-term treatments are based on insufficient evidence. I'll like to say a little bit more about where I think short-term interventions play their role. So we have a situation like this, and I don't think this is untypical. This is from Westminster, Kensington, Chelsea, where I work. We have probably around 2,500 people in contact with our mental health services who have a primary diagnosis of personality disorder, and less than 1 in 50 of those people has access to our specialist treatment service. So, how can we go about improving this, knowing that there are some more resources for mental health, but perhaps not lots more resources for mental health in the coming years? Well, people have written a lot about a stepped care approach, and it's been used to think more effectively about how to use resources for treating people who have common mental disorders, and I think it has potential for helping people who have a diagnosis of personality disorder. And the basic principle is that you offer people services in order to generate the best outcomes whilst burdening the person as little as possible. And some of our long-term treatments for personality problems are long-term. But in order to achieve this, we need to improve the quality of care delivered by community mental health teams, we need to develop, test and deliver short-term interventions, and we need to reserve the long-term treatments for those who haven't responded to the low-intensity interventions. How do we go about improving care delivered in community mental health teams? I don't think we can underestimate this. There has been, in the last 10 years, a lot of good work, and I see that in my practice. People particularly have done the KUF training that was supported by NHS England and has begun to make a difference in people's knowledge and awareness and capabilities for working with people with long-term personality-related mental health difficulties. The principles of care are well described, excuse the typo, but my experience is that there are difficulties that people working with community mental health teams have in differentiating acute and long-term risks. Because a lot of what's delivered to people with psychosis is looking out for risk factors associated with crises, and we need to have a different way of thinking about people whose everyday thinking and feeling might have thoughts of self-harm or suicidal thoughts, and that requires a different approach. We also need to avoid a situation in which there are extremes and services are inconsistent, and I think it's really difficult for community mental health teams who are very often quite stretched, responding to crisis after crisis, to step back and think about how they can provide a consistent service to people who do not respond well to inconsistent care. And another thing which the specialist services are familiar with, but community services sadly are not, is that it's very hard to provide effective treatment for people with personality difficulties unless you've got staff who are properly trained, but more importantly, properly supervised. And there is very little space in community mental health teams for reflective practice. But I think without that, it's very hard for people to make sense of the interpersonal challenges that they will face if they truly want to engage with people who have difficulties in their relationships with others. We need more evidence about the effects of low intensity interventions, because it's not good enough to have CMHTs trying their best or a 1-2 year program of intensive psychological therapy. People used to say there was no point in doing something short term, but we've got some evidence from America that web-based psychological treatment programs may be effective. There are some generic interventions like structured clinical management, good psychiatric practice, which appear to have benefits, but that's from sort of observational studies. And there's also been a lot of interesting work, as the point was made earlier on, working with people with lived experience to co-deliver treatments. This is an example from one of the pilot projects that was set up looking at service user-led support groups for people with personality disorder. It's observational evidence, but it showed that people were less likely to end up going to A&E or having inpatient admissions when they've been attending these service user-led support groups. And short forms of mentalisation-based treatment and dialectical behaviour therapy are being developed and tested. This is the only slide particularly that relates to something I'm involved in. We were funded to try to develop a low-intensity intervention for people with personality disorder, and we did that in collaboration with service users and carers. An expert panel used lived experience to guide us in the development of what we're calling psychological support for personality. And it is a bit like you say, a bit of this and a bit of that, based on the available practice. But our experience so far, interestingly, this is an individual level intervention. It's not delivered to groups because some people find it very hard to engage in the group-based therapies, which are the dominant model in the country at the moment. What we're finding is this is an intervention which people are engaging, are attending, and with Barbara Barrett's help, we'll have some good economic data within the next few weeks. I've already said we have 1 minute. I have 1 minute. Specialist high-intensity services, there are limited numbers, and no matter how much additional resource there might be, the places are going to remain limited. What we know is that the costs of providing care for some people who are high service users are incredibly high. But sadly, there isn't a good economic evaluation of psychological treatment of personality disorder. We do have some good economic data from a drug trial that was done last year, and that shows high levels of inpatient treatment, contacts with general practitioners, and we know that if you look at the data from trials, it's the people who have the highest levels of service contact and the greatest need who appear to benefit most from those interventions. So it does seem right that we should be reserving those high-intensity interventions for those people who have the greatest need and highest levels of service use. So to summarise, the diagnosis of personality disorder, you're looking surprised, I'm finishing on time. The diagnosis of personality disorder is not very helpful for many patients, as are many mental health diagnoses. But they are really important if we're not going to misdiagnose and mistreat people who have got personality difficulties in mental health services. The concepts of personality disorder have been around for a long time. They've been accepted by policymakers, not just in the UK, but internationally. And we have evidence-based treatments for people with personality disorder, but we need to think more carefully about how we use that limited resource and develop a stepped care approach for helping people with these difficulties.
Okay, thank you very much. Any questions? Oh, Rachel?
Yeah, can we go back to the case example slide that we had for a second?
The very early slide.
Yeah.
Yeah, it's right at the beginning almost.
Yeah.
It's taken from the diagnosis, no longer diagnosed exclusion of the
Yeah, I think it's further back.
It's really right, there it is.
Yeah, that one. I'm just interested in why you chose that example, because I think that the idea that the only reason women like trying to kill themselves is that they've had an argument with their boyfriend is a persistent and damaging myth, which I've certainly, I mean, I'm gay and I've had, oh, did you have a fight with your boyfriend? And I also think that choosing a quote which frames what I would imagine is much more likely to be an incident of abuse, given that you say she's been in violent relationships with men, as an argument with her ex-boyfriend. That's something that, I mean, having worked in domestic violence services, that's a difficulty that we come up against a lot. Like, the police will see an incident of a man abusing a woman as, oh, they're just having an argument. So I'm just interested in this context in particular, where we're talking about the impact of trauma and the way that gets misread as someone's personality being wrong. I'm interested in why you chose that example.
So, I mean, the first thing I'd say is that we know, of course, from research in the community that the prevalence of personality disorder is as high amongst men as it is in women. But the reason why I chose this example was because I wanted to make sure that at the start of my presentation, I made sure we were orientated towards thinking about the severe emotional health difficulties that people with these problems experience. And that's why I've highlighted the emotional state of this person. I could give you many examples and vignettes of people I've worked with who have personality problems, but there's issues getting consent, and so I use this example because the authors of this NHS report have got the consent of someone to describe this vignette. So,
consider the stereotypes and the harmful things that might perpetuate by putting it in this presentation.
I wanted to illustrate the experience of emotional distress that's experienced by many people who have personality problems.
I'm going to take one more question while Rachel shimmies to the front. Where are you? Yeah. Quickie, please.
Make it quick. I'm one of the people you're talking about because I've been in community mental health services for 25 years with a diagnosis of our label of BPD. And I just think how I've done DBT, I did find it really victim blaming, telling me that I've got disordered personality, that I should stop self-harming, that I should eat more, the things that have kept me alive. And I'm trying to stay polite. As a person who's been in services for 25 years, I just don't understand how there can be some sort of trauma or basic care for people who've got the diagnosis or the label, and you're saying short-term therapy. I don't know. That's just what I want to say anyway.
Okay.
I'll go back to chew my pen. Thank you.
Yeah, I mean, I think there are. Whatever the condition is, there'll be people who've had bad experience of services, and whatever services are provided and provided in the future, some people will have positive and some people will have negative experiences of those services. I think we need to be honest that not everyone is helped by the treatments that are currently available, but we do have good evidence that when taken in totality, people who are offered these evidence-based treatments have better lives and better emotional health than those who aren't offered them in total.
Okay. Thank you, sir.
Much better at looking at our informatics and working out when is someone struggling with a service and then providing them with a different sort of approach. So in short, and I've used the progress note entries not because I'm saying this is how we should judge whether someone goes into service or not. I'm just trying to illustrate a point. So this graph, okay, so there was one person who had 1,300 progress notes entries in 1 year. So that means several a day. So it's saying something about the staff, how they're they're responding to their anxiety, they're putting something on Rio, or in our case Rio, and so on. So it's a sort of a proxy measure. And basically you can begin to cut up your pathway into different chunks and have different interfaces. And obviously there does need to be flexibility between the different chunks. Our clinical strategy it means that we have different sorts of approaches, and this is where the work of the Royal College of Psychiatrists cross-faculty working group is coming into it. So tier 2, which is your sort of general community mental health team population, it seems to us that psychological education, actually that's wrong, so psych ed and signposting, but also structured programs like DBT, MBT, etc., where people can straightforwardly engage in a program. Tier 3, we're sort of identifying people who are really struggling to engage in an outpatient-based therapy program, so they need that more sort of day TC type approach, where it's much more relational, it's much more about engagement, it's much more focused on sorting the setting out, in the hope that you will then get them, if they want it, to be able to take up a psychological intervention. And then tier 4 is much more about putting those two together, providing both setting and therapy together. So in West London, this is what we came up with. We came up with a pathway where we have social prescribing services and a managed clinical network which supports training and consultation. And that surrounds a tiered approach to our interventions. And then you can actually describe much more detail what those tiered interventions will look like. You can have copies of the slides later if you want, so don't worry. And we've got a mixture of recovery, college interventions, and mainstream psychology, psychotherapy with psychiatry and so on. So it seems that Tier 2, though, is a very core part of working in the long term, but Tier 3, they come in at particular points in time in someone's care pathway. And this is far too busy, I don't expect you to look at it, but basically we're beginning in the Royal College of Psychiatrists just to bottom out a bit more detail about the tiers, because I suppose the National PD programme it's somewhat unfinished business, really. They set out the ambition for tiers, but I think there's a lot more work that was needed to be done to describe in detail what we mean at each tier, who we're trying to target, distinguishing the difference between the intervention and the service, and so on. So my conclusions, though, as I said, is I do have concerns about the label, but it's the lack of services which is what is a far greater concern to me. There are people at the moment who are not getting a good service, and there are serious consequences for them. I do feel there is a moral case for doing something, and I do think the economic arguments are overwhelming. So I just want to say thank you to some of the staff at the Castle in West London who helped me put this data together. But so there, thank you very much.
Fiddling in your pocket. For a good reason, really. Now, do we have any questions for Oliver? Who's speaking to us?
It's just about I noticed on that big thing with lots of things on it.
Sorry.
Big matrix. You have right at the bottom, you had IAPT and personality disorder. Could you say a bit more about that?
So at the moment, it gets a bit fuzzy. Some IAP services will just say if you have a sniff of a diagnosis of personality disorder, we're going to exclude you. Some will be more tempered and say if they feel they can offer someone with personality disorder a short-term intervention, they will. So I do think there is a role for short-term interventions, and I think the NICE guidance is behind the curve here.
Hi there, thank you. You've clearly put a lot of work and covered a lot of different things there. I think given that we're talking about the degree of trauma, abuse, continuing assaults that people are vulnerable to, I'm wondering where a recognition that there maybe needs to some advocacy or some safety planning built in, because there is no point in trying to offer psychological support. Certainly post-trauma work if the trauma is still ongoing.
So I really haven't drilled down into detail about what individual programs. So structured clinical management, its first phase is about making people feel safe. But I would also say that that's actually the first step of any tier, any intervention, any service. If someone is not safe, how on earth are they going to make any sort of progress? Absolutely.
Hi. Can you just tell me a bit more about the formulation you mentioned, as in who does it? Is it team formulation? Is it with a psychologist? Is it with a nurse?
So I can talk about my own personal approach to formulation. So in my team, we have psychologists, psychotherapists, nurses and social workers, and we practice team-based formulation. So every assessment is discussed, and we're trying to approach we're trying to offer a relational approach to our patients. So I mean, for me, formulation is not also something you do and you write down on a bit of paper and then give to somebody. It's an ongoing. It's a moment-to-moment process.
Come on, users. It's a psychiatrist up there. Can I ask him a hard one?
NICE guidelines, I believe that it was updated last year, but sorry, I have like, so I believe it was updated recently, but there wasn't actually much service user involvement in it, and they said that there wasn't that much that changed, but there is actually a lot going on, and they should have got involved with the wider community.
So I mean, I'm afraid I don't have much to do with NICE, so I can't really comment on that. But I think, in my view, there is a lot more epidemiological evidence about what we should be, why we should be doing things, and there's a lot more economic evidence. I think there's also an enormous move to recognise the impact on physical health, which is different. I suppose where I have a bit of sympathy for them, though, is I don't think we are... what we should do hasn't particularly changed very much. And if I think about services which have been developed in recent years, like perinatal and so on, they have been developed on much less evidence than we have for personality disorder now.
Okay.
Hello. When you're actually considering formulating PD services, to what extent do you think of PDs beyond borderline PD and the social PD? Because very often PD, especially in the media, is presented as being homogenous, very bad, very loud, very demanding. But there's a whole range of personality disorders beyond the headline personality disorders which rarely get a look in. And it can be so hard to find treatment if your personality disorder falls in one of the quieter, less demanding, less presenting as an acute risk PDs.
So our tier 2, my service I would describe as a tier 2 personality disorder service. It doesn't particularly have any exclusion criteria at all, and that includes eating disorders and other comorbidities like drug and alcohol, etc. And the tier 3 service I mentioned, although it is sort of designed with personality disorder in mind, it doesn't actually have an exclusion criteria or inclusion of you have to have a diagnosis of personality disorder. It's just whether you actually feel the service and the patient can work together. So, actually, and also I want to say just something about the way I approach personality disorder as a diagnosis is that although I never worked there was a very famous hospital called the Henderson Hospital, and it said the diagnosis of personality disorder might have brought you to the store, but you can now leave it there. And I think that's quite a good way of conceptualising the difference between personality disorder and formulation, I think.
Yes, pity the Henderson's closed.
It is.
I was just thinking that some of the research results that you had were quite similar to ones that we had when we were looking at the personality. Well, we don't really have a personality disorder pathway in Birmingham, but we were looking at the results of people who use acute services. So I was thinking it's very similar. But the one thing that is interesting that we're going to pilot is we were thinking about a lot of the work that we did in Birmingham was co-produced with the services network that I work with, and we yeah, sorry, losing losing track. Here we go. But what I was going to say was that one thing that was brought up by services in particular was that you often find out about your diagnosis kind of in a very backhanded way, and that discussions aren't being had between kind of clinicians and service users. I was just thinking that the combining some of the points that are coming up from Rachel's talk and also from your own one, it seems that relationships are really important. So we're piloting some work at the moment where part of our pathway standards for that when it comes to diagnosis, nobody should be diagnosed without an initial conversation with the service user first of all, and the clinician, diagnosing clinician, and to have a discussion beforehand, and that would include sort of discussion on the impact of personal, that label, and also what services could be accessed, and just something to kind of just start that ball rolling. So it's something that we're about to implement. I was just wondering what you were doing with these different tiers. I was wondering what you were doing kind of.
So I think this is a really interesting point, and it goes obviously it explodes the dilemma around diagnosis, doesn't it? It puts it focus right on it. So I'll tell you what happens now, and I'm uncomfortable with it, but I'm living with it because it seems the least worst option. So the personality disorder services at tier 2 are called personality disorder services. And so when someone refers someone to us, we say, look, have you had a conversation with them? And if they haven't, then we won't accept the referral. And that changes behaviour distally away from you. So you are affecting all these different services around you and hopefully addressing that untreatability fantasy that exists, because you're making a positive step towards something, and hopefully it is changing the stigma. Now for tier 3 I think it's slightly different, because you will have to have had that adjunctive tier 2 service anyway.
Okay,
Oh,
Sonia.
sorry.
Yeah, I just wanted to say what I understood happened with the NICE guidelines, which is that they did what's called a surveillance to decide whether there was enough new evidence to revise the guidelines. And in fact, rather amazingly, given that they hadn't been revised for 10 years, they concluded that there actually wasn't enough new evidence available to revise them, which is quite depressing, really.
Right, you're looking angst-ridden, but time is also on. Is it a quickie? It is. All right, well, hang on. We need to get the microphone because the elf is. We're broadcasting.
Hard of hearing.
Chaps out there can't hear you.
Yeah, where do people go if they don't identify with personality disorder in your service? What about deeply traumatised young people? They come to your service for the first time. They need help for these, what we've already identified as deeply traumatic events that have happened to them, and they're faced with having to accept a personality disordered identity or nothing. What do they do?
So there's a couple of things. So first of all, I have patients in my clinic where we use the complex PTSD diagnosis, but we also have around it the complex depression, anxiety and trauma pathway, and I think we're just trying to engage people. I mean, I'm not saying we have the answers, that it's the perfect system, but it feels a lot better than when I started in 2003.
Okay, final quick question.
Yeah, it's a comment really. It was just thinking about, I'm from a women's organisation working with women who've experienced various forms of gender-based violence and trauma, and it's just that understanding about that we're providing tier 1 services. We are so not. We're working with those women who come with a plethora of diagnoses, so we are doing that psychological in-depth work, because actually referring to statutory services, you're seeing someone for a quarter of an hour every month, if they're lucky. So I just really wanted to make that point about, but we're under-resourced and we don't have the funding, so, but there's this whole hidden world that is happening for survivors of gender-based violence in terms of what they can access and what services like ours can provide.
Yeah, I'll take that back. Thank you.
Okay, thank you very much for the grilling. Sorry for the question and answering session from Oliver. Thank you for that. Okay. So Sue is coming up now. I was once told I had a personality disorder in a very small, sweaty sort of research room. And it was slightly one because there was a very thumbed copy of 50 Shades of Grey in there, which it seemed that was more disturbing than most, I think. Have a wand. Have you got a PowerPoint?
Yes.
Right, hold on.
I hope so.
I'm multitasking here. And you're away. And there is a clicker. You have the power.
I just want to say a couple of things. Several of you have spoken already of nicked bits of my speech, thank you. Secondly, hello to my wife, who's at home with a bad back. She's watching the live stream. There it is. My name's Sue Sibbald, and my personality is not disordered. I'm a wife. I'm a mum of 2 beautiful girls. Well, the women now. One's just hit 18, and I'm gone, oh my God, what have I done here now? Set them up into the world. I'm a human being. And I just want to tell you a bit about bits that I do. I'll talk about it a bit later, but I work for Sheffield Health and Social Care Foundation Trust, so I work for the NHS 4 days a week. And I work privately 1 day a week, so if anybody likes what I do or talk about, I'm here for a fee. So I run groups and with people and their families, which I've co-produced alongside psychologist colleagues. So I run staff training as well, and I've worked about 8 years now, so I've got a lot behind me. And I was co-chair of the consensus statement for personality disorder with Norman Lamb, and I'm not sure even how I got there. Still today, I have imposter syndrome. Still up here right now. I'm a northern girl, and I'm a peer worker. Okay, so personality disorder, the diagnosis of controversy. I just threw a load of words out from my head to do this title page. It just came out because I think it's just, people talk a lot about it and all different things, and there's raging arguments go on. And actually, one of my first times on Twitter was, I'd never heard of personality disorder when I got diagnosed. I'd not heard of the thing. My mum had schizophrenia, my nephew has autism, but personality disorder, not heard of it. Borderline personality disorder, definitely not heard of it. And so I just think it's so when I went on Twitter and discovered people saying what you have does not exist, it felt a bit invalidating for me at the time. But I've got to understand more about what the arguments are about now, and I'll talk about that a bit later. So here we go: complex needs, PTSD, trauma, manipulative, raging PD, attention-seeking, splitting, angry, can't be a patient, doesn't exist. Sorry, can't be a parent, and I am. Untreatable, abused child, neglected, overwhelming emotions. And then all these arguments went on. I remember being on Twitter one day, and Jackie Dillon it was Jackie Dillon actually, and she said, it doesn't exist. And I started having this big row on the middle of Twitter with her, probably about 6 years ago. And we are sort of friends on Twitter now. I've never met her, but this argument has been going on for so long. What are we doing? What are we doing? We need to be galvanising ourselves a bit more. So, if you want my opinion, the label needs to change. That's my opinion. As I said, I don't think, whatever it's changed to, I don't know. I think the people that have the power, I think Jay mentioned before, it's Peter Tyrer and his lights. They have the power to change the label, but they're not going to. But I think it's a daft name. I ran a poll on Twitter quite a few years ago, and people were choosing different options rather than personality disorder. Some people hate the label, and they've got every right to. You know, it's been people have been gate kept out of services. I know, I work in the CMHT, I see it happen. I see that happening. People are gate kept out of services because the services have been cut to the bone. We used to have 4 community mental health teams, we only have 2 now. It's absolutely awful out there. And this is something we need to be thinking about as well. You know, is this extra money coming? Who knows? So people get kept out of services, nitrogenic harm piling trauma upon trauma. I want to give a trigger warning here for suicide. I'm just going to talk about. This was about 5 years ago on Twitter. A friend of mine, her Twitter account's there, Silently Anna. She went to A&E twice and she was tweeting this, and she was told she was attention-seeking and manipulative. And she tweeted that. And then the next minute, she was sent away. She disappeared. She'd driven a car into a tree and died. And I just think this is the sort of stigma that's happening, and this is what's behind this label. Some people like the label though. There's Padan on Facebook, Personality Disorders Awareness Network. Last time I looked, they had 600,660 odd people who followed that. Quite a lot of them like the label. It is global. And what I want to say about the label as well, if we want to change it, we've got to be thinking globally, not just UK. It's a global thing. We've got to put the pressure on. There's DSM out there. You know, I got told I had BPD, that's DSM, by a psychiatrist in 40 minutes.
Oh, as long as that.
It was a long time. So I did have words with him after. I also tell this joke as well, because he always told me I was well kept, but I don't think he was. He was a bit of a mess, quite frankly. So people like it, and there's people like talking about BPD on Twitter as well. Nearly 7,000 followers. Talks about her, you know, talks about BPD. So there's people out there that like it, and I think because they found it validating. But you know, I'm not here to argue with them. However, most people agree there are better ways to describe people other than being told that your personality is disordered. There must be a better way. Come on. There's some huge brains and there's some huge money out there being paid to people in the NHS, and people who use services have probably got better ideas about it, but we need to. And that's my thing. We need to be asking people what they want. We need to be asking people because we're crap at that. You know, we shouldn't just second guess, and just because that's what we believe. You know, I believe this or I believe that. It's not about that. It's about asking the people what they want. That's important. Always forget that. Most companies who are private companies, I'm from a background in nightclubs actually. I worked 22 years in nightclubs, and then trained door supervisors for 2 years. So that's my background. And we had to ask people what they wanted, because if you didn't give them it, they'd go. And I think we should be asking people a lot more. Okay, I'm just going to touch on a couple of slides for Alex Sturzaker now. She was asked to speak here. She was a woman who brought the consensus statement together, and she couldn't speak, so she's sent me 2 of her slides, which I'm hopefully going to do justice to, but these are her slides. So the consensus statement, shining lights in dark corners of people's lives. Statement for people with complex mental health difficulties who are diagnosed or labelled with personality disorder. Nice guidance, here we are again, mentions DBT and MBT. And I was, unique part of my speech, so is it Sonia there? Because I was going to say, NICE didn't update the guidance because there was nothing there. You're one of the people who nicked bits of my speech, but yeah, nice guy. They weren't changed at all, but they need to be, and hopefully the research that's going to come out of this will actually help the nice guidance to change, because DBT and MBT work for some people. That's true, that's a fact, but it doesn't work for everybody, and we can't go around putting people on boxes, and it can't be the only thing that's on offer, but it does help some people. I taught myself DBT and I use it because it is just life skills. It's skills for life. It's not a rocket science. And I learned it. I'll talk about it a bit later, but I did learn it myself. So it's not that a difficult thing. There's growing evidence for structured clinical management, Bateman and Kravitz. So that was 2013. So structured clinical management sort of looks at, in a structured way, going through about how to help people. So you might look at, whether they do look at the diagnosis to start with, whether you agree with that or not. They go on to look at things like crisis management, whose let me think of the words, whose responsibility is what between people. They also look at things like crisis management, and what I like about it, it looks at drugs and alcohol as well at the same time, because often we have drugs and alcohol services, although they've been cut as well. And we have other services, and they don't work together. It's like, you can't have therapy because you're on drugs and alcohol. Oh, you can't come in the drugs and alcohol. Oh, you go and have therapy. So people are just swung between these places. So it's a good thing that they do that. They also involve family and friends, and I don't like the word carers sometimes, but anyway, carers. They involve people. So it's quite a good way of doing things, and they also use formulation. So that's structured clinical management. And then there's international evidence growing for a step care approach within generous psychiatric services. And those people there, and John Gunderson actually is just recently passed away actually, which was rather sad. He was quite a big person in America, John Gunderson. And I'm going to read this about step care approach because it's the words of Alex, so I'm just going to read what she says. It's a move towards a generalist approach to care, particularly with people entering services for the first time. It's a positive approach, building on strengths rather than seeing people as unable to cope. And I like that because quite often, I don't know how many times I've had to go into services and tell people what's wrong with me, until you just start to believe what's wrong with me, not what's right with me. So I like that strength-based approach. And so it's a positive approach and more effective, and service delivery is not risk averse. So it's taking those positive risks, because I see it in my own place. I hope my trust aren't watching this. But I see it, you know, oh no, they're self-harming, they can't possibly do DBT, and it's like, bloody Marshall Linehan wrote it for the most suicidal of suicidal people. Get them doing it. But this happens, you know. So it's less risk averse because, you know, I think we should be doing it, and it works collaboratively, so you're working alongside with people. And then people will be stepped up to more intensive treatments when appropriate, but it's important to give people a chance early on in their history. I think that's key, giving people a chance early on, not waiting until things escalate, because that's what I've noticed in my CMHT and throughout. We're just talking about crisis care all the time, and beds and crisis and how we're going to manage. We're not talking about the prevention, not talking about the community work. We've slashed the community work, we've slashed public health, we've slashed everything that actually will prevent and help people. And working alongside families in the community, you know, there's so much we could be doing in a more holistic way. Okay, so there are Alex's slides. I've embellished them slightly, I hope she doesn't mind. Oh, no it isn't, here's another one, sorry. This is her slide as well. So, we need shared ownership and true collaboration. And that's key for me as well, because people talk about co-production and engagement. And what I find, you know, this happened at my trust as well once. They came along to our service user network and said, what do you want to call the ward? We thought we might name it after one of the parks in Sheffield. So I just went, ward number 1, because I was so pissed off. You know, did you really want to co-produce, engage or anything with us, or did you just want to tell us what we were meant to do? Choose from 5 or 6 of the parks in Sheffield. But co-production doesn't truly happen often. Collaboration doesn't truly happen often. And we need to think about what that is. Yeah. I've 1 minute, no, I've got 30 minutes.
What?
Yes.
Yeah.
I have. I'm doing per slides.
All right, well, you can vote. Go on then.
Okay, I'm nowhere near finished. So good relational practice where the person is, or a flexible approach based upon shared understanding tailored to the person's needs. Good relational practice where the person is understood by services to enable them to feel safe. And that's that relational thing. It's about relationships are key. Someone's mentioned it already. Relationships are really key. And service need to be integrated into the community with long-term sustainability and planning evidence. That's about people across the lifespan need care. People across the lifespan need help and care. That's important. Because I think I might need to go into services again at some point.
We're always recruiting.
I might do, you know. Something might happen to me. I'm out of services at the minute. And staff need to be supportive, competent and knowledgeable. And once again, Alex is echoing the punitive nature of the diagnostic label of personality disorder needs to be replaced so that people who could be given the label are treated with more respect. What people said, so this was 263 people asked by Renson via Twitter what they wanted, and they wanted a consistent professional who listens carefully in the right service setting, confidence in services, knowledgeable, competent and understanding staff, connecting with other service users, normalising a person's experience and increasing social contact. And theme 4, a choice of interventions including creative therapies and collaboration across all services. So these are important things. And I think the theme 3 about, we're going to talk a bit now about peer working, because I think it's really important. So, peer support. These are 2, I'm a peer support worker, so I'm going to talk about it because I think it's really important and there should be more of us. But peer support is generally understood to be a relationship of mutual support where people with similar life experiences offer each other support, particularly as they move through challenging or difficult experiences. And that's Scottish Recovery Network 2018. Peer support is a system of giving and receiving help founded on the key principles of respect, shared responsibility and mutual agreement of what's helpful. So there are two things about what, and that's Mead et al. I think there's two types of peer support. There's formal and informal. There's a bit of a hoo-ha at Ensign recently about formal peer support workers can't be proper peer support workers, and informal is the only true type of peer support working, but I think both can be it. So there's online peer support. That happens on Twitter all the time. I see it. I started a chat called BPD Chat 7 odd years ago. That still happens. And people come and support each other and meet each other. There's a Facebook group where I learned DBT. There's a Facebook group still, which if people want to go and learn DBT, they can. It's on there. And it's peer-led. And people learn from each other. So I think peer support is really crucial, and I see people on Twitter supporting each other constantly all the time. That's a type of informal peer support, and it also goes on the wards and in community groups. And there's formal peer support. So peer support works in the NHS, and we've got 4 of us on the personality disorder. It's called the personality disorder. Pathway, and they all work in the community, and they're all paid, and they work in educational groups, or they work one-to-one with people. So people who can't do groups, we can work one-to-one with people. And as I said, yeah, they're all paid. And then finally, I feel a bit rushed here. I'm going to talk about validation, but I'm going to take my time over this, because I was just saying to Jay before she left, was that validation is absolutely the key thing to helping people. I think validation is emotional first aid for those in crisis. And I think it's really important. And I'm going to tell you a story about validation. This is a story I tell wherever I go. So wherever I speak, I do this slide and I talk about validation. But my daughter went on a bike ride. And she went with my wife. And off they went, and I was in the garden gardening. And she came back really quickly, and I was like, what's happening here? And she came down the path, and her little chin's wobbling, and like, oh no, what's happened? She went, the chain broke on my bike. I'm like, oh no, you're so sad. You really wanted to go on that bike ride, didn't you? And she was like, yes, I did. I went, well, what do you want to do? And she was like, I just don't know what I want to do. And I went, okay. Rhubarb growing, she liked baking. Do you want to bake a rhubarb crumble? So she said yes. So she went into the house, baked a most beautiful rhubarb crumble, which I had with custard. It was really nice. Take 2. If she could have come down that path, and I'd said to her, big girls don't cry. You can go on a bike ride another day. I know what would have happened. She would have run down the path, because I'd totally invalidated her. I didn't connect with her feelings. She would have slammed doors, and most importantly, I would not have got a rhubarb crumble. But that connection with people, that showing you understand, for people who have been truly invalidated as children or as adults, constantly still, is really key. And I think it's key for teaching staff. I'd love there to be some research on validation. There's actually a book called The Power of Validation, Arming Your Child Against Bullying and Self-Harm. But I think it's really key, and it's really important. And then the last thing you'll be pleased to know is we talk and talk. We spend so many hours talking about personality disorder. And I think it's key about getting people help. That's what I'm here. I'm BPD FFS on Twitter, and that's actually fighting for services and for fuck's sake as well. But we spend our time. How many years have we spent arguing over the label? And you know, I'm there for fighting for services. I want people to get the help they need. Label needs to change, yes, but we need to get people the help they need. And I'd just like to say though. I'm glad all these people are in the room today, and there's loads of people out there. There's probably millions watching me on live stream. But what I'd like to say is, just a quote from Martin Luther King. our lives begin to end the day we become silent about the things that matter, and people with personality disorder matter, or are labelled with it. Thank you.
Sue's wife.
Yeah, hi Julie. Hope you're back better.
Okay. Obviously, any authoritarianism I attempted to bring to the session was completely usurped by all insisting and talking. So you'll be pleased to know that we've eaten into our breakout session, but we still have plenty of time. And this is where we get you to do a little bit of work. Obviously, we've heard from a lot. Hang on. Here we are, here's a thing, and a little doodad. I can press one of those and see what happens, you know. Off you go.
Oh, I don't wreck things, I do apologise. I recently had surgery, so I'm still in pain, so I just blame it on that. I'm not usually so clumsy. Right. So basically I'm going to consider a little mixed bag of things in this presentation. Suggestions about possible way to rename the term personality disorder, and thinking about reading onto the Proof's work and how to design community services, that kind of methodology. Right, this is why we are here. I presume everyone knows this because they've been here longer than I have today. Right, one of the things that's often forgotten about personality disorder is the sheer heterogeneity of presentation. It's not just about BPD, it's not just about dissocial PD, it's not just about self-harm, it's not just about antisocial behaviour. There's a whole range of symptoms that present in the context of what is called a personality disorder. And these are just a few which are drawn from the diagnostic criteria which are mentioned. There's more paranoid, schizotypal symptoms, the more dissocial symptoms, the more avoidant symptoms. So we've got virtually everything that can go wrong with a personality there. It's not just BPD, it's not just dissocial PD.
Mm-hmm.
Right, one of the common factors, which may be a feature of all PDs as opposed to mental illnesses, is the egocentonic nature of PDs. Now, I'll give you a very clear, very simple example of this. Take OCD, which is a mental illness, and take obsessive-compulsive PD or anancastic PD, which is a personality disorder. For someone with obsessive-compulsive disorder, OCD, the mental illness, they very often have full insight into the fact it is an illness, it feels alien to them, they know their anxiety is irrational, disproportionate, they hate it, they hate the fact that their rationale is insufficient to quash the anxiety, so you've got a real conflict within the person. Mm-hmm. Their rationale, their logic, their reasoning is telling them one thing, their emotion is telling another thing, and the emotion is often winning, and it's agony. Now, if you take something like the OCPD or anancastic PD, you get similar kind of traits, concerns about things being right, things being that you are on time, that you are expressing yourself as you should be doing, that everything is safe and good. But when this leads you, because these traits become excessive, into problems, you kind of feel yourself aligned with the problems. You kind of feel that your traits are justified. You recognise they may be causing you a problem, but you don't really feel them as alien to yourself. So you've got a much greater alignment of the rationale, someone's sense of identity and how they see themselves and how they see the world and how it all functions, than the emotions. So you don't get that brutal conflict of mind and emotion within the personality disorder that you get within the mental illness. So that's just an idea. Perhaps PDs could be called egocentonic disorders. It's just an idea that's out there. because then it contrasts well with the mental disorder, which is often ego-dystonic. So you get the clear divide, but it's less pejorative. You've even got the PD has a nice syntonic. We're all together within the PD. We don't have the conflict, the inner conflict of the mental illness. Right. Again, when it comes to PD services, I think there is a general consensus. You know, it's always a good idea to ask patients. But institutions take a long time to change, and ways of working take a long time to change. So whenever people are doing, as the PRU is, research into what is out there, what could be out there, you know, gaining the patient, the service user input and feedback is so important. And this leads into design thinking methodology, which is about designing things which are centred on the user's expressed needs and views, and what works best for them. And this has been currently being used to good effect recently within NHS England mental health secure care, where there's been an awful lot of work done using the design thinking methodology to design a community model for forensic service users. That's beyond the Tier 4, it goes up to the secure sector, but community services nevertheless. And more recently, around more specific pilots for female forensic service users and getting them out into the community. Right, so this is a bit about design thinking methodology. It's designed, you know, to solve complex problems, real world problems. It brings, similarly as we've got here, a wide range of stakeholders together to share knowledge, views, opinions, contributions, experience. It's strengths-based and it's solution-focused. It's very practical. It's about considering what can be done, what the needs are, what can be done, what strengths we can play to. And it's viewed as a 5-step process. Find out what's happening with everyone concerned, all the stakeholders, define the problems, define what's needed, ideate, think around how these problems can be solved, think about designing prototypes and then test them out via pilots in the community. And again, it's iterative. You can go back at any stage. So it's very real worldy and practical. Again, it's a helpful breakdown, but again, reiterating, these are not steps that you have to slavishly follow. I know when we've done them with NHS England Secure Services, we've done them with a series of meetings with stakeholders, and basically each meeting involved an iteration again, but going through with what we had already worked on and developed and refining it to develop a consensus. Right, and here are what the outcomes are so far. That was when the design thinking methodology was carried out in late December to February a couple of years ago. That's basically how we followed the methodology. And although it was 4 workshops, which doesn't seem a lot, they were about 3 hours long each, and an awful lot of work, and a lot of it was very constructive and good humoured. People were working, saying what their experiences had been, what worked, where they'd experienced innovation, what worked, what didn't work, and it was, you know, very cohesive, lots of ideas generated, and prioritisation of those ideas within the groups. Right, what the final outcome was for the forensic mental health community service model. That's a quick short breakdown, and a lot of the things are familiar and what would have been expected, but it was very important that this came from a consensus of stakeholders. And these are all components which, you know, within to varying degrees would be expected in any community service. Obviously, with very often with forensic services, you've got an emphasis on the substance misuse, you've got an emphasis on the education and employment, because very often people in secure services are being locked away for years, not to say decades, and they really do need that support. And again, specialist case management, because of all the issues that offending presents, both at an individual and a community level. Right. That's the pilot stage, the final stage of the design thinking methodology. We're fortunate that it's been very well funded, but then since secure services are a low volume but very high cost service, and there are lots of concerns about length of stays, lots of concerns about whether or not patients are getting the appropriate treatment as inpatients. That sort of extra support for community services is so very important. An evaluation of the programme is underway, and that evaluation has also been formed by service users who have experience either currently or in the past of forensic services, and they have been involved in determining the outcome measures, which outcome measures are used. Currently, this is more hot topic at the moment. This is more, we've just basically evaluated applications for funding for the women's pilots, and that again was evaluated. I think about half the evaluators of the applications are actually female forensic service users, so it was a very well balanced evaluation of the application process, and that's what's going to be implemented in the very near future. So design thinking methodology is very useful. It does yield concrete results. That's it. Very short.
I love you.
Thank you.
You caught me out there. I didn't even get a chance to wave my little bit.
I don't waste time.
Wave bits of paper about. Okay, wrong. Then I'll stop the stopwatch. Right. Has anybody got any thing they want to say? Questions or comments they want to say about what Sarah has said? Stunned silence. Absolutely.
Oh, there's one question.
We got one. Hold on.
Yes, I'm just curious.
Right, we'll start again.
Yeah, I was just curious because you were talking about co-producing in secure care with women. I was just wondering how you did that. I was just thinking about the power differences between sort of women in secure care and actually being able to design their own care. I was just wondering.
I think a lot of
how you.
I think we're very fortunate within secure services. There's been a lot of very structured work done around developing PPI. Simply because, as you say, there is such great power differential. Those patients are literally excluded from the community. So the ground was already there for patient and public involvement. For the past few years, there's been what's known as the Regional Recovery and Outcomes Group, which has been literally going round to various secure units, doing presentations, mainly about recovery, sourcing patient views. So that was the backdrop of this. And so via that very same network, the Recovery and Outcomes Group, the notion of the need to develop a community service, a new community model for forensic mental health services was advertised, and service user views were gathered at those regional meetings. Then the invitation was given out to those same service users to come to the workshops. Now obviously that is then dependent on whether or not they have the right Section 17 leave. But within that there was still opportunity for them to bring their views via their peers. But within the workshops, because people in secure services, they're often viewed or labelled as being the most disruptive, the least educated. When you get to speak to them, very often you find, okay, they may have had poor educations because they've had disruptive upbringings, but they have so many very good views. And they've been in the services 24/7, day in, day out, for months and years. So they know how services work, what's wrong, what might work better. And, you know, the richness of the views and the very groundedness of the reviews was really good. So it was a very easy process. And it was led by Justine Faulkner of NHS England, who's herself originally a mental health nurse, and she has complete esteem for those patients. And that was very much the working within. So although there are massive power differentials in terms of epistemic esteem, it was literally a flat playing field. So it went really well.
Fantastic, thank you for that. Any other thoughts or comments? No, I think you got off the hook there, Sarah. Thank you very much for that.
Thank you.
And absolutely, user involvement is actually very easy in some ways with people in secure settings, because apart from the fact they're captive, they are a captive audience.
But also because, you know, they really appreciate the opportunity.
They appreciate the opportunity.
And they need it.
And they need it, and
yes.
And it's a huge, you know, validation for them. But they can bring so much expertise. And I can remember talking to a manager a few years ago, and they were designing a new unit, and he had the users involved with that because they're better at playing spot the ligature point than staff are, let's face it. So if you bring people in who know, then you really are going to be, you know, trying to make some real difference with people who experience it, but also fully appreciate it. So, I'll move on now to Shirley McNicholas.
I'm here.
Hello! Hello! Are you ready to go?
I'm ready, yeah.
Okie dokie. Now, you can have a doodah.
Yeah.
Talk into it like that.
Yeah.
You can have a clicker.
Okay.
And actually you can point, which is completely pointless because they're really tiny. But there you go. So without further ado, so Shirley's
the clicker work.
the little red. That's him. Yes, that's that.
Okay.
So yeah. So well, you explain who you are.
Okay. I know some people in the room, but I'm Shirley McNicholas from Camden and Islington Foundation Trust, and I've been running Drayton Park for 24 years, and I'm the founding staff member of Drayton Park. I think I've been asked to come here today because we have a particular model of working that is now called a trauma-informed service, but years ago that wasn't the language that was used, and we were feminist, we were empowerment, we were women together, all sorts of things. But I suppose partly because women come to stay at Drayton Park, women with a range of diagnoses, but a large number of women come and stay who have been given the diagnosis of a personality disorder. And our experience is that women with that diagnosis and with most diagnoses prefer to try and stay in an alternative to hospital and somewhere that isn't about their diagnosis.
Try using the mic.
Okay. I'm not loud enough. I feel like I'm really shouting.
Well, we're also sending this out into the ether,
Oh, I see,
so
I
the
see.
people in the wider world need to be able to hear. So.
Okay, sorry, wider world. So we call it
They'll
the
get
Drayton
over it.
Park model, and we were established in 1995. And there's a little logo there, which is ASDA, which is Awareness and Response to Domestic and Sexual Abuse. And that was a particular project we did in the Trust, and we still do, and is very relevant to the work at Drayton Park. So in terms of what people need and want, they want the right kind of environments to come and stay in. Many people, many women want environments that are not units. We don't use that language at all, to try and offer people services in homely type environments. So that is Drayton Park, kind of like a Fawlty Towers really. And the right setting, we've got a beautiful garden, there's artwork on the wall which women have done over the years. So having a women only service, women coming from all sorts of backgrounds have brought art and creativity over the last 24 years, whatever the diagnosis. So we were established in '95, and as I said, we were founded on trauma-informed principles, and I'm sure, as everybody knows here, trauma-informed care is based on the understanding that many clients have suffered traumatic experiences, and the provider is responsible to be aware of that fact and to work with it with every person, assuming that every person may have had some experience of trauma. Evidence of childhood abuse is overwhelming in women, and I'm sure in men as well, although there's less research, and is underreported.
I'm sure there's lots of research about being subjected to sexual abuse, physical abuse, the impact of domestic and sexual abuse. Hind Khalife did a piece of work with our trust and trust in South London, and that the women who had experienced domestic and sexual violence were much more likely to kill themselves. And also a trauma-informed approach is about thinking about other layers of oppression, discrimination, poverty, the global violence against women across the world. When something terrible is happening to a woman in another country, it's happening to us here. And the impact of benefit cuts in relationship to trauma, proving your worth, not being believed, having to kind of sell yourself. And some women describe it like being, prostituting yourself to the benefits again and again in order to get your money, to prove your worth. So it's kind of trying to hold an awful lot of that. So some of our founding principles that was kind of implicitly trauma-informed was around validating experience, so involving women who've used services in the design, the functions, and creating ongoing systems for feedback. So from the very beginning, the first advisory group had lots of women who were using services in Camden and Islington, and some of those women are still in the group today. And they were in a steering group, they wrote the job descriptions with me, they interview all the staff, looking at policies, and hearing the diversity of women's groups, so reaching out to women who might not come forward to ask their opinions on what helps. The choice, we're the only women-only team I know. 24 years later, we've never convinced anyone that it is okay for women to be looked after just by women, and that we'll all survive together without men being in the team. But we managed to do that in 1994 with no question at all. And at Drayton Park, that's never been questioned. Nobody's ever tried to make us have a mixed team for a normalising experience for women. And overwhelmingly, the numbers of women coming through, and women report the benefit of a women-only environment, knowing they're speaking to only female staff. If they wake up in the night and they're not fully dressed, it will be a woman that they bump into outside. And that the staff skills, that it's broad skills, it wasn't professional background, and it still isn't, so it's not a medical nursing traditional team. We wrote just job descriptions based on skills, experience and attitudes, and then kind of graded those posts. And from the beginning, embedding a culture of acknowledging the social and political context of women's lives, so that's one of the questions that interviews when people come to work at Drayton Park, tell us about the political and social impact on women's lives that cause them to have mental health problems. And it's a good indicator if somebody's on it with all those things. Trauma-informed approach, working as if every woman you meet has been traumatised, therefore routine inquiry, meaning you ask everybody whether they've had experiences of sexual, physical or emotional abuse. And confident about safeguarding adults and children as a women's service, rightly or wrongly, there is a lot more talk about children. Lots of women are single carers of their children, and at Drayton Park we can accommodate the children. So we have to have a high level of engagement with children's services, and providing child-friendly space for women to see their children, be with their children, and children kind of being held in mind even if they're not there in the building. Just one of the pictures of Drayton Park. It is the health service. There are things, infection control inspections, ligature assessments, all sorts of things that have come over the years that potentially have unintended consequences of damaging this therapeutic environment that you're trying to create. So you have to kind of hold on tight, but also respect some of those very real risks.
There's still place for cushions.
There's still place for cushions, but I'm not allowed to go to IKEA anymore. At the beginning, everything was from IKEA, as it was at nearly every health service. So just kind of the action. So you can't just have principles, you have to see where you live out your principles. So referral systems being clear and simple. They're taken from any time, any source, 24 hours a day. Anybody can pick up the phone and make a referral. So self-referrals is crucial for a trauma-informed approach. That doesn't mean every woman who self-refers. We take the referral, offer assessment, and she comes in. It's the same as anybody making that referral. Assessments are offered in the house, facilitated by women, embedding routine inquiry and kind of issues of FGM, trying to remember to ask every single woman who comes. She comes from a community where FGM is practised. Places offered with a clear time frame. So I suppose thinking about the group of people you're talking about today, women who, in my experience, have nearly all been traumatised, where they don't believe people lie to them, don't take care of them well, where they have quite extreme reactions sometimes to us not being on time, on breaking boundaries, all that kind of thing. So at Drayton Park, trying to be really clear about the boundaries, what we can do, what we can't do, what choices you can have and the choices you can't have. So we offer everybody a week, but we've had to cut that to kind of 5 or 6 days. So when someone comes in, and it's a maximum of 4 weeks, but the average length of stay is about 2 weeks. So as the statutory service, as a crisis service, we've got to show that we've got a high turnover. So it's very important when women come and women who've never been before to say, we're offering everybody a week, you're not going to get a 4-week stay, which somebody else may well have promised them. So you're already breaking some promises somebody else has made. And we have agreement plans, so when we set up the service with women, we talked about language, how language is so important in mental health. So we have agreement plans rather than care plans. So the agreement plan is much more like a contract of what we're going to do together. Language is crucial, so it's collaborative as much as possible. Expectations, you can expect this of me, and I expect this of you back. Robust containing risk framework for staff and women to follow. So I won't, but we have very, very structured routines for the staff that women aren't necessarily feeling it as structured as the team are. So we're on them all the time because we're a house for women who are at high risk, women who have tried to kill themselves many times, women who self-harm very badly at times, women who are hearing voices telling them to jump out in front of the traffic. So it's really, really important that the team are very clear all the time they're working with people who would otherwise be in hospital, but that the women experience the house as somewhat relaxing and therapeutic. Team decisions daily. So because we don't have the traditional sort of a ward round or a team meeting once a week where the authority figures come, it means every day decisions can be made with the women you're working with. On this shift this morning, the worker and the woman might agree a night to spend at home, a referral to make, a date to leave, rather than we have to wait for senior staff to come around. So the model is set up. And in crisis work, you need that. Daily house meetings to share information, increasing sense that people come. This is who's on shift later, this is the food. We've got visitors coming, there's going to be workmen coming, really trying to kind of be open about information. And again, closely in partnership with children's services. We have a weekly support group that we just had a break from, but we started again. And although it's a crisis service, as the only women-only service early on, we provided a weekly support group for women to come back to. And I would say there are a lot of women with that diagnosis who come back to that group. So they are in other services, but to be held in mind, to know we're there is, for many women, it's a real kind of stepping stone to the week. And it diverts quite a lot of self-referrals. People call quite anxious, feeling they need to self-refer, and saying, coming to the group, for some women that's enough, and it holds. And we haven't really researched how effective having a group in a place where maybe you told your story for the first time, you had some sessions where you felt believed and validated. Not everybody feels that. It's not, you know, Disneyland. 5 minutes. Okay, images everywhere, so we try and kind of make everyone feel welcome, every woman feel welcome. So there's different notice boards that you walk in, and if you're gay, you might come think, oh yeah, this is a place I can talk about my relationship. There's a Black Women's Forum, there's different notice boards. So the trauma-informed environment, as I said, choice to have a women-only space, self-referral, trauma exploration assessment. A domestic violence setting is really important to the having carpet on the floor, soft furnishings, things like that are very, very soothing. Information presented with diversity. We've got body therapists, so from the very beginning we've had body therapists rather than kind of OTs and more traditional in crisis work. Really, by the time you've had assessments, it's time to go again, and that has been really powerful for so many women to have some body work. The team trained in trauma interventions using essential oils for grounding and things. Everyone's offered one-to-one sessions twice daily, and we have the Women's Strategy Group, which feeds into Drayton Park as well as the wider trust, but we always meet at Drayton Park. Practicalities, as I've said, referrals taken over the phone, assessments at the house, admissions, 4 to 5 a week, average length stay, all the medication mainly is prescribed by GPs, so we're really embedded in the community and with the voluntary sector and with the local chemist, where we need to get Tampax or, you know, various things that we've run out of kind of thing. So really being in the community Housing's a very big issue. 4 children can stay at any one time. Diverse range of women stay, including transgender women. Another bit of lovely art. People can see this afterwards, really. It's the day in the life. Quite often when we're doing training, it's like, how does this function day to day? How many staff you have on shift? That kind of thing. Women say lots of things. On the whole, very positive. Other times, you know, you promised me everything and you've really let me down. This isn't what I wanted. I want to stay to full for weeks. You're throwing me out. This is very disempowering. So, you know, it's not always, we're not always doing the right thing, or sometimes we're doing the right thing and people don't agree. Let's see some of the things women say. Another picture of us. Survival of services. So I've just put something out when people are kind of, how might we set up a women's crisis house? What kind of things, and how you survive, really. All the changes that have come and gone. We're really still almost exactly as we were when we started, except probably about £200,000 less.
Yeah.
And so this, and I've just put the 2 research projects we've had, some further reading, something by Judith Herman, and artwork, and that's it.
All right.
Thank you.
Okay. Don't run away.
No.
Did anybody have anything they wanted to? Yes, here we are. I'll give you that back.
Okay.
Just trip over here. Probably trip is the right question. The way of putting it. Hold on. I would leave it in another way.
So you mentioned Black Women's Forums. There's generally this perception, and that's backed up by the evidence, that there is an underrepresentation within PD services of BME community service users. So is that your experience, or do you find that there's much more BME community service users access your service?
Well, a lot of BME women access our service, but I would agree not that as many are referred or use the service with that particular diagnosis. So, and also as community services, that pattern continues, that BME women, particularly African Caribbean women, are at the much harsher end of mental health services. So, which is why from the beginning we were really trying to promote that and holding a Black women's space where Black staff and Black women who've used the service or any trust services can come together 4 or 5 times a year and have a forum to kind of really hope that Black women feel there's a place for them, trying to do some positive recruitment a couple of times, then I got caught. But in terms of, you're right, from the teams that provide services in our trust to people with those diagnoses, I think there are less BME women in those services.
From your experience of 24 years, why do you think that is?
I don't have an easy answer for that, really. There isn't a particular, I'm not going to.
Okay. Anybody else? Sonia gets her arm up. Hold on. We're going to get to. This is going to be tricky. I'll come back here.
Just wanted to ask you what you think about PD diagnoses and when women have them, and whether there's anything different about the way you work with women who are from that service or have that diagnosis, and what you think of that.
I mean, how I think and feel is, I hope in my lifetime that is no longer considered a diagnosis. I feel it has a really, really negative impact on the women who come and stay. People feel, of course, that someone's saying there's something wrong with them and their personality, their personhood. It's really damaging, which doesn't mean some of the service provision in our trust, you know, it's the MBT, the individual work, some group work, some managing emotions, learning how to name your emotions, some of the therapeutic input that is offered to those people with that diagnosis has been really, really helpful. And that's often we're trying to say to women, you know, try and see beyond that label you've been given so that we can refer you to that team, because that team can provide some really good services. but it's really painful to be given that diagnosis and unhelpful, which, you know, and most of those women, in my experience, nearly all of those women have experienced some kind of trauma, but not all of them have experienced a trauma, but something's happened which has made life unbearable, incredibly difficult to manage. And one of the things that people found helpful coming to stay is that, as you were just kind of saying, having, you know, a named worker system. So even in crisis work, within the house, there is still somebody leading and working most closely with you, instead of, often in a crisis response, it's somebody different every day. It could be a man, it could be a woman, it could be this person, and there is something about consistency and trustworthiness and authentic as well that is really, really important in terms of what we provide. But yes, I would love to see that diagnosis stripped away.
Okay, so there might be a ripple here of applaud for that.
Hello? Yes. Yeah, maybe I'm best to answer that because I was in Drayton Park twice with that diagnosis and at no point was that diagnosis ever used, and it was probably one of the most helpful services I've ever had, and thank God I had it. When I lived out of this area, the Islington area, I didn't have access to anything like that and was stuck in like a kind of iatrogenic cycle with my acute mental health services that were treating me really badly. So when I got to Drayton Park, it was the first safe place I felt I was really understood, and no one spoke about me in ways that were disgusting, actually. But I was just wondering, I've got a question, actually, is that Drayton Park, I know, is like the only service of its kind in the whole country, a female-only space that's trauma-informed, and I just wondered what your thoughts were about why that might be, Shirley.
Well, I think misogyny. I think women aren't as important. Women aren't held in mind in most statutory services unless it's in the women's sector. So if it's domestic violence, everybody kind of understands that women are the victims of domestic violence. In secure services, in prisons, people seem to think it's okay to have women-only services, and then we come to mental health services and it seems this isn't the right thing to do. So I always hear it should be mixed staff teams. It's not normal for women to only be with women, when so many women in my life find it perfectly normal to have times they're just with women, as well as people having fantastic relationships with the men who are in their lives, in their own personal lives that they've chosen to be with, or fantastic care coordinators, but they don't want to see them in the middle of the night when they're not dressed. So I don't know why there hasn't been that kind of investment. I mean, I know the other two women's crisis houses in London have now closed as well, so some of those other women-only services haven't survived. And on the other hand, I know in Slam they're all single-sex wards, but they're not single-sex staff teams, and people continually tell a story, and I don't think there's any research in this about women don't want to work with women. Nobody wants to work with women on their own. You know, women are really difficult when they're just on their own, is what people say about women's wards all the time. So a fear gets generated about just working with women and women-only teams. But South London and Maudsley are kind of talking about a women's crisis house at the moment, so let's watch that space. And Madrid, as I was telling you earlier, we were invited to Madrid. There's a whole movement there. They've got grooming together and they're hoping to set up a women's crisis house. Yeah, they are fantastic.
There's a queue.
Crisis Point is part of Turning Point, and there's 4 places across the country, and it's mixed, men and women, and you can go there up to 10 days. And last year I was there, unfortunately, 3 times, and you're there and no one knows what your diagnosis is in the community area, and that it's really, really good. And half of the people that were there are the service users, or like they tried to call them guests at one time, and I thought they'd give them a bill or something to do a guest. But it's really, why can't, like your place, there be more of them? I mean, it makes so much economic sense, And then just lastly, with all the domestic violence centres that have closed across the country, but in your area as well, has that had a knock-on effect with the people that you're seeing?
There's always been a very high overlap, if you like. Lots and lots of women have come to Drayton Park who are in acute mental health crisis triggered by current domestic abuse. So that's always been a kind of very big factor. The refuge spaces in our areas and around London, there are still quite a lot of refuge spaces. So I haven't seen that particularly impacting, but I think what I have definitely seen over time is that, and what I hear more is doing safety planning, working with people who don't want to go to a refuge, who want to stay in their own home, who actually have good relationships with their mental health teams. And so giving all of that up when you have got a significant mental health problem, where you really need services to support you, it's too big to give up. So we have to get much, much better in adult mental health and integrate and work with, and I'm just doing a project with some people at the moment about getting some IDVAs into the mental health services, because some of our teams, every single day, they're working with the domestic violence services because there's so many active, high-risk cases with and mental health involved. So it's much more about us getting much better at safety planning in people's own homes as well, because not everyone can go to refuge because there isn't enough space, and lots of people don't want to. But I haven't particularly noticed the refuge spaces closing having an impact, but the levels of domestic violence have definitely risen, or our awareness of them has definitely risen.
Okay. Thank you so much. It's good to hear there are places, sanctuary, that obviously work well, and we get a first-hand account there of somebody saying, I've been there twice and it was the only place for me, so it's good to hear that, and so thank you very much. So, without further ado, can I ask Professor Paul McCrone to come up? There we are.
Right.
Here you go.
Thank you.
So we're going to talk about the economics of all this?
Yes, so we've left economics to the last session.
Yes.
Last talk, anyway.
Yes, the most riveting presentation.
So, I mean, people say that money talks, but I prefer Bob Dylan's quote that money doesn't talk, it swears. So, which I think is fairly appropriate. So, what I'm going to do in this session is, well, by way of background, first of all, I'm an economist, I'm not a clinician, and I've been working here at the Institute of Psychiatry for the past 27 years nearly, which is very scary. So, and I've worked on many projects. I do lots of evaluations. I work with clinical colleagues. I work very closely with people using services, social care colleagues, policy makers, and others, people commissioning services. So I've worked in many different areas. I haven't done an awful lot in looking at services for people diagnosed with personality disorder. I've done some work in this area, and I've got some data that I'll show you a bit later on. But as part of the project that the Policy Research Unit wants to do, is one of the things we want to do is look at the economic impact of innovative new services. So we're going to be trying to identify key services around the country and use those and investigate those more, talk to people who are using those services, people who are working in those services. But we also want to do look at the economic impact. What's the impact on costs, and are they cost effective? So that's quite an important thing to be looking at. And some of the services, like we've just heard from Shirley, and some of the other models of care that we've been talking about in our groups and during the day, they're the sorts of things we want to be looking at and doing some evaluations of those. So I thought what I would do in this session is give you some background to health economics, a very sort of whistle-stop tour of some of the concepts that we use in evaluating services from a health economic perspective. So some of what I show, you might think, well, why is that relevant in this particular area? And it may not be relevant, and it would be good to have that discussion in our groups later on. Some of the things that are relevant, some of the things that are less relevant. But I thought it would be good just to give you some of the ingredients that we use when we're conducting economic evaluations, and show you some data, and then talk briefly about some of the work that we may be doing a bit later on. So I hope that's okay.
Yeah.
You might start off, why on earth are we bothered about economics anyway? Why are we bothered about looking at the cost or the cost effectiveness of different services? And this is a slide that I'll probably show in almost every talk I ever give. I'm actually going to start amending it and changing it somewhat, because I've been thinking more and more about this and thinking more and more about how we do economic evaluations and the importance of economic evaluations. I think they're important. It sort of pays my salary, and I think that we need to be making sure that we're using resources in the best way we can. But I'll start off here by saying that resources are scarce. We've all got a certain amount of time available to us. We all have 168 hours a week. So we've got limited time. You're all spending time here this day, coming to this meeting, this workshop, and you could be using your time in other ways, presumably. There's other things that you could be doing. So you've got a scarce resource. And of course our money is scarce as well, so our own individual money is a scarce resource, and the money allocated to the health service, to the social care system, to the education system, to society, to any area of public spending is limited. I think to some extent, this is why I want to change it. There's a bit of a cop-out that actually it is actually a political decision how much we spend on healthcare. It's a political decision what cuts we make in healthcare and social care. Austerity, whether you agree with austerity or disagree with austerity, it was sort of a political policy decision to restrict the level of spending on social care and to try and contain spending in healthcare. So these are political decisions. I think even if we, but having said that, if we doubled spending on healthcare, it's still a finite resource, isn't it? We still have a finite amount of resource going on healthcare or social care or any other form of care. So I don't think this is wrong, but I think we do need to address the total amount that we spend on healthcare as well. And that's, we should be, I think, as people working in academia, in our ivory towers of academia, and out there in the real world doing research, working in services, we need to be campaigning for appropriate resources as much as we can, as well as making sure that we're using resources in an effective and appropriate way. So resources are scarce, but the demand for those resources is fairly unlimited. And certainly within healthcare, we know there's various reasons for that. We know that people are living longer, which is good, but it means that if people are living longer, they're more likely to, at the moment, develop dementia, Parkinson's disease, certain types of cancer, etc. And so the ageing population means that more and more conditions are going to be experienced by more and more people. Technological advances, what do we mean by that? I don't necessarily mean, wonderful new ways of imaging or new drug treatments or things like that. I mean new ways of providing community services. We've been hearing about Drayton Park, which has been around for 25 or so years now, but it is in a sense, it's a technological advance. It's a new way of working. And the question was raised, well, why aren't the services like Drayton Park elsewhere? And there is a demand for services such as that, because there's been evaluations of Drayton Park that show it to be, a good, cost-effective service. So it should be rolled out. So when technology advances, like in developing services like that, there will be a demand to use those resources in that particular way. And of course, there's enormous expectations about what the health and social care system can do, and what our communities can do as well. When we're talking about people diagnosed with personality disorders, and then we're unpacking that and looking at the limitations of that, of those diagnoses, those labels, and we actually start thinking about, well, what do we mean? Who are we talking about? We realise that people are going to be using many different services and engaging with many different aspects of the community. And there was a report from the King's Fund, I'm not exactly sure when it was published, but they looked at health status across the population, and they found that healthcare services only accounted for at most about 40% of differences in the level of health that people had. So yes, healthcare is incredibly important. If I'm unwell, I want to get appropriate healthcare, but there's lots more that's going on that's going to contribute to our quality of life, our healthcare, our health status, etc. So we have scarce resources, we have high demand for those resources, and so we're always having to make decisions about how best to use our resources. What is the best way of providing care for a person presenting with a specific problem or range of problems or challenges in their lives? And So that's one question that could be asked, and other questions would be how much do we spend on healthcare compared to education or defence or the police service and things like that. So these, without health economics, without people like me doing economic evaluations, these decisions would have to be made in some way anyway. So we try and inform that decision-making process as best we can. Health economics, economic evaluation is not just about cost. Cost is incredibly important though in any evaluation, but we need to think, what do we mean by cost? And we always, well, economists always say that what we actually mean is opportunity cost. Cost arises when we engage in a particular activity, and by doing so we're not doing something else, which sounds a bit of overly theoretical in a way, but it is important because obviously a lot of care that people receive is unpaid. People will get lots of unpaid care from family members, maybe friends, going down the pub, you know, just going for a walk, meeting people. There's no remuneration for these inputs that may benefit people. So when we're thinking about cost, we need to think about value, which represents what has been foregone. How do we actually measure costs? What do we actually mean by costs? Well, whose perspective are we thinking about? NICE, which make recommendations about how healthcare money should be spent, focus on costs to the health service, but usually we want to go broader than that. We may want to look at the whole public sector. We might want to take a more societal approach to thinking about cost. What costs would we include? Direct treatment costs. You know, treatment, what do we mean? That means you're doing something to somebody, doesn't it? But you know, direct care costs or therapy costs are obviously important to think about. But what about other services as well? So again, picking on Drayton Park, just been hearing about it, but it may be, if it's keeping people out of inpatient care, then that's another thing that we need to include in our evaluations. Let's measure inpatient care. What's the impact there? Productivity costs, are people being able to get into work or stay in work? And that may not be a good thing. It may not be good if people are in work. Work actually may be causing problems for some people. So we don't always want to see, you know, increased productivity as a good thing. It may be a very bad thing for some individuals. So let's always remember that as well. It's not, in economic evaluations, we often think, oh, people are getting back into work, which is one of the selling points of IAPT when it was first rolled out. People will get back into work. It might not be a good thing for everybody to get back into work. So we've got to be, you know,
somebody said it.
Well, you know, sort of engaging more in leisure activities and things like that, and having good social networks can be more important sometimes. How do we measure costs? I won't go over that. That's just how we would do it in a evaluation. And where do costs fall? Well, they fall all over the place, don't they? So we've just got many different areas there. So the general public, the education system, employers, family caregivers, mainstream healthcare, and of course mental health care services themselves are important. Now, are costs good or bad? Do we want to cut costs? Well, maybe, but not necessarily. Sorry, it's a bit vague, this talk, isn't it? I'm posing lots of questions. But what is cost? Cost is a monetary representation of things that go wrong for some people. If somebody becomes unwell, then that may affect them in adverse ways, and that's a cost. But it could also be a monetary value of the very positive care that people are receiving. And so we could have bad costs or good costs, and these aren't hard definitions. And you could easily argue that medication, for example, that's not a good cost. For some people, it may be a bad cost, but you know, if you've got a headache and you take a paracetamol, that could be a good cost that's incurred. So, you know, these aren't hard and fast definitions, but let's not just think about cost as being negative. It may be that we need to increase costs to provide appropriate and adequate care. Stigma, we've done a lot of work on stigma over recent years, and that has a cost. It's very hard to disentangle what the cost associated with stigma is, but some of the effects of stigma may be causing barriers to receiving appropriate care. It may be causing disincentives by government commissioners to invest in specific services, and there may be impacts on employment as well, so reduced income and things like that. So stigma is something that we have been looking at over the recent years, and we want to be doing that more. I won't really go over these data. These data are all published. This was the PEP study that was led by Mary McMurran at Nottingham, and is looking at community services for people diagnosed with personality disorder. But we measured service use, we measured costs, we did a cost effectiveness analysis, and that's all published in the HTA monographs. So just for the sake of time, I won't go over it in any detail, other than to say we measured a whole load of services that people were receiving, and lots of variation in that. GPs, psychiatrists, seen by lots of people, but this was a trial, so it's a bit, you know, it may not be entirely representative. We looked at daycare. Daycare was incredibly low use of daycare services, and benefits. Lots of people receiving different welfare benefits. And that was the distribution of those costs. But as I say, that's all in that monograph, and so I won't go over it. But ultimately, what we don't just want to look at cost. And when we do the work in the PRU project, we want to look at cost effectiveness. And that means that we want to look at the relationship between cost and outcomes. Cost is just a monetary representation of the care that's provided, remember, or the adverse effects that people experience. And we want to see how that, well, if we're looking at the care costs, then how do they relate to outcomes? And it may be that by increasing costs we get much better outcomes, and that we can, you know, that's something that we need to be thinking about and measuring. So it's not necessarily about reducing costs. And there's many different ways of doing this. Again, I'm not going to go through all of this. Other than to say that what we usually do in our studies is do cost effectiveness analyses, where we look at the cost of one form of care compared to another, and we use a single, I'll say disease specific there, it's a very general terminology, outcome measure. That may be entirely inappropriate when we're looking at services for people diagnosed with personality disorder. It may be best to do something like a cost consequences analysis, where we just look at the whole range of outcomes that may be experienced by people and look at all of those alongside each other. 1 minute. So different options. How do we do these evaluations? Well, we could do a wonderful randomised trial. That's totally impractical within the time frame of what we're doing and within the policy research unit generally. We can look at routinely collected or observational data, and that's something that we have been doing in other PRU projects, and where possible we would do that here. And we can develop simulation models. So it's a bit jargony, but it's basically not collecting new data, but looking at the literature, looking at service models that exist, and just modelling what the costs would be if people use those services, and what the cost effectiveness would be. So the PRU project, these are just some of the things we're doing within this, and some of this has been talked about already. So we're doing various reviews of the literature, identifying current innovative models of care, developing models to estimate costs and cost effectiveness of existing pathways, and then using those models using the forms of care that we identify, the innovative forms of care that we identify, to see how those pathways might change if those ways of working are rolled out more extensively. And that's it. Just in time. Thank you.
Well, thank you very much, sir.
Pleasure.
Let's turn this up on. It's too early in the day for that joke, isn't it? Okay, so you hang on to that. Right. So, anybody who has anything they want to ask of Paul? Oh, the hand goes up. Hold on.
Thank you, Paul. I spoke to a senior strategist once who it was enough. And they said to me that if they only looked at the economic cost of investment and the limited financial envelope of NHS and mental health, then when you look at the personality disorder group of patients, that we are a very heavy cost burden on the NHS, because we take up so much GP appointment time and other services time, and a lot of our comorbidities, such as alcohol and drug misuse and eating disorders, we're a very expensive NHS group. And if you look at the other mental health groups like psychosis, children, young people, perinatal, it's more cost effective to spend the money on those groups, as has been done in the 504 review. And the early suicide rate for personality disorders is actually, if you purely look economically, it's more beneficial for us to die young. So we spend fewer life years being a burden to the NHS. So I mean, I couldn't answer that, and obviously they didn't know that my diagnosis. So can you help me out? How would you, being with your experience and articulately, would you answer that argument?
Yeah, I mean, it's a dreadful thing to say, isn't it? For them to say that. I mean, on the cost side of things, you know, what sort of burden, as it were, are people on the services? If people have needs, then they should get appropriate forms of care, which may be very costly. So yes, it may be that I don't know the data at all, but let's assume that it's true that people diagnosed with personality disorder make more use of GPs and go to A&E more, etc. Well, that's reflecting needs, isn't it? It's reflecting the needs that people are presenting with, and so you know the health service and social care system should be providing the care inputs that people are requiring. Obviously, yes. I mean, if you could provide the same level of care or better care at a lower cost, then of course, yeah, I mean, we'd all want that. I mean, that wouldn't be a problem in itself. If you can get the same, at least as good outcomes for less money, then yes, do that. But if it's reflecting the needs people have, then it's entirely appropriate. People are turning up at GPs and A&E and you know, maybe going to A&E as a result of not getting enough GP care, of course. And then in terms of you know the other point about well, if people die early, is that saving the NHS money? If you looked at it in pure monetary terms, just in impact on the health service, yeah, you may argue about you know children dying or you know anyone dying before their time, as it were. But of course we always have to look at outcomes as well. And so one of the things I didn't mention, and we often use these quality adjusted life years, QALYs. And I'm no fan of QALYs, but we use them. But one good purpose of QALYs is that it represents the amount of time people spend alive and their quality of life. So the longer someone lives, quality of life being equal, then you get a better outcome, obviously. So you know, if we're looking at outcomes and we're looking at it in terms of how long people live and their quality of life, then we would want to extend life as much as we can, because that's on the outcome side, that's on the effectiveness side of things. So.
Okay, thank you for that.
But it's a point that people often say that, and you think, well, yeah.
It's always a bit worrying when a financial academic says we need a good plague or a good epidemic just to clear it out a bit, and just save a few bob. I paraphrase.
From what you've said, the amount of variables that you could use to measure economic impact are almost infinite, and I'm just wondering how on earth do you decide what gets measured?
Yeah, you've got to be pragmatic, of course, and we've got to do it in an appropriate way. And I mean, in most of our studies, we do interviews with people using services and say what services have you used in the past 6 months or 12 months, whatever. And yes, we could have an endless list, but we know if we want to, it's a bit of a problem in one sense, because if we want to work out what the total cost is, then we know what the most expensive services are. We know it's inpatient care, we know it's outpatient appointments, we know it's visits to A&E, and so if we want to work out what the total cost is, we can be fairly clear what things we need to measure. But actually, if we want to unpack the cost and say, well, what are the care inputs people are getting, and how do those care inputs affect their outcomes and quality of life, actually the list can be very extensive, because you can have very inexpensive services that are positively benefiting people. So it could be, you know, voluntary workers, people going to their local church or mosque and seeing people there, or you know, helplines and all those things which aren't particularly expensive, and so wouldn't contribute much to cost, but definitely may contribute to the care inputs, the level of care that people are getting. So it's not really answering your question, and we just have to be pragmatic and say, well, we can't measure everything. We know the sorts of things that contribute lots to cost, but we don't want to just restrict it to those high cost items. And I think, importantly, we want to go beyond the service system as well. We want to, you know, if somebody has a particular health problem or a set of problems in their lives which mean they can't, you know, they don't feel confident to go to the cinema or something, that's a cost to them. That's a welfare loss to society, because somebody isn't experiencing things that they might want to do. And you know, if we want to take a very broad approach, we could be looking at all the impacts on leisure activities and social networks and things like that as well. So it's complicated, yeah. I mean, economics is not it's a social science. It's very much a social science. It's not it's not finance. It's not accountancy, and finance and accounting are very important, but it's not that, it's the social science.
Okay. I'm off to see Mary Queen of Scots next Monday, so how does that end? Is it happy? I don't know.
I can tell you about Stan and Ollie.
That's a lovely film. I thoroughly enjoyed that. That was very life affirming. Any other questions for Paul? Okay, you can grab him. Well, we're going to have a break. Be lost. It would be nice to have some feedback. Then the elf can. You're going to tweet it or stream it or do that with it. Yeah. So. Okay. So you got the short straw for this table, did you, Steve?
Yes.
Okay. Well done, that man. Well volunteered.
So, on first of all, I see this on calculators. First, we discussed various models, so there are quite a few mentions of particular models in here. First one being the path model, Gene Fader. This is in response to the first question. Being able to disclose being validated and contained, references to more general support, particularly being supported with PIP applications, therapeutic communities were mentioned. These are all, as I say, all different possibilities to consider in the scoping models. Validating the EIS model, early intervention service.
Mainly about how the label schizophrenia has been sort of quietly, sort of suppressed in those services in a way without actually completely losing contact with the evidence that might be relevant in a way that has think about.
And then just to naming emotions, being able to work through and express feelings and how it happens to people. And there's some discussion about DBT, elements which were helpful and elements which were more debatable, and some different types of places where that's used.
Rachel thought that the DBT model was meant to be a long-term intervention.
There's
actually
actually
been turned into a quick turnaround, short-term.
there's a very big gap between the evidence base and how it's actually used in practice, and that's quite important. Like, there's no point looking at models without thinking about how they're implemented.
Yeah, absolutely. I've heard that so many times.
Yeah.
Cut down versions of DBT.
Where it's just like, here are these skills that you don't have. Do better. Like, now it's not therapy.
Some discussion around the steps and owning the PD labels. That's around that kind of discussion about the difficulty in not using the label, but in fact people still get the label in their records. The impact that has.
I think people are saying that some elements of the steps therapy is really helpful, but the introduction to it is almost like you have to sign up and say you've got a personality disorder, and then you can get on and get rid of that part, and then the rest of it can be helpful.
Some discussion around the kind of long-term therapeutic relationships and the value of those, which I think we've touched on. Holistic approaches and more spiritual ones.
then of course we also had a discussion around trauma services and trauma services which might not have a PD label, and making sure that the work captured, found all of the found those.
We were just talking about
help him out.
Yeah, I just because I'd talked over him throughout the entire thing, I thought you could then look it out. We were talking about training all the staff, all the professional groups. There's no mandatory trauma training. There's mandatory everything else. Everyone comes out qualified, but actually not qualified because they have not had any training in trauma work.
Yeah, we have a page 2. I don't know where we have time on.
I'm talking about like non-pathologising spaces and how important it is to have spaces that are non-pathologising and don't use diagnostic frameworks in order to support a person in distress.
We just listed on the other side services that actually do work with people who would be given that diagnosis. They're just like the Bristol Self-Harm Services, Survivors UK, Solace, Women and Girls Network, Drayton Park, and I'm sure there's others, leading Solace Women's Aid into the Iris Project. There's many of those people who, if they came to the attention of, they would say they've got a personality disorder, but they've been helped in all those different ways really, because we were looking at models.
I'm noting that quite a few of these are not NHS services and tech services, and how we would fit them in within the research.
Okay. Anything else?
Just to mention parenting and drugs and alcohol.
Yes, please.
No, I just wanted to mention them as important challenges to be not forgotten.
Absolutely. Flip there, but absolutely. Who's going to go on this table?
I'm going to summarise the slide.
All right. Okay. Go for it.
So for the first point about important things to consider, the group talked about having a model that's flexible and can be adapted to the needs of people. Flexibility came up quite a lot as a theme. The importance of having continuity of care and having a service that considers the entire needs of the population. So those people that may be within the group that are not necessarily being supported by perhaps the usual provision that's offered. Having a personalised approach, taking a relational approach with clear staff supervision and support, reflective practice. We talked about the CUF programme and how that is really, there was a lot of investment in that, but that seems to be kind of dwindling, and that, it's a good model that it's already reached about 100,000 people. It would be worthwhile putting some more investment in there and updating some of that work. Although training is important, the main need is to have services that are available to people and are well resourced. Is there any other key things on the first point that I've missed?
So in terms of what important elements, we talked a lot about sort of choice, mainly available in therapies. We talked about sort of integrated models, which would be helpful. We talked as well about kind of having support for staff as well, because obviously it's quite difficult in some of the discussions we had about diagnosis earlier, very whole-team approaches would be helpful. We discussed a sort of single point of pathway for referrals as well, and how there has tended to be sort of previously a research focus on where it's easy to research in terms of looking at models and what would be good to integrate community services, maybe thinking wider kind of more group trajectories would be helpful. We talked in terms of maybe having some sort of we had a lot of discussion about sort of increasing sort of knowledge of voluntary sector services and increasing sort of partnerships between them. We talked a lot about kind of integration with kitchen services as well in the voluntary sector. and we talked a lot about lived experience as well, and you know, sort of professional roles, as well as having kind of like separate maybe peer groups, acknowledging complex needs, and having a space. We were talking about voluntary sector services where, you know, open discussion of kind of uncomfortable subjects like suicide, for example, is kind of having a safe space to do that would be helpful. And we talked as well about kind of like navigation in terms of sort of navigating the support that's available out there, and again with the community services maybe having kind of some more sort of like points of inspiration around that as well. And on terms of continuation into care, that's really important, but also that it's helpful for that to have some sort of endings as well, to kind of a more realistic model of being, I suppose. And providing a welcoming sort of environment, perhaps a sort of home environment, celebrating diversity, and
Okay. Right. So you can have a working environment, but you're not allowed to go to IKEA. Okay. Just remember that. My old friend. Whoever. I mean, this is a Dali-esque write-up of. Good luck, Kylie.
I think that everyone's probably getting a little bit tired, so we're not going to go through every single point.
Please don't.
So Emma was suggesting we just focus on the hub of hope, but I think that she could maybe think about that better than I could. No. I beg your pardon. I'm so sorry.
Yes.
To get into a wrong.
Okay.
Sorry.
Going to do a quick advert, are we? Okay, go for it. Need the magic wand.
I'm part of a mental health collective, national mental health collective, and there's a young man who's won an award. He's called Jake Mills, based in Liverpool, and he's created like a Just Eat app, but it's for mental health services. So you put your postcode in, and it will tell you what mental health services are in your local area, what time they're open until, and if it doesn't, if there's none in your area, it will give you the national details. And there is a stringent process to go through. You know, you just can't email and get logged on to it. And he started, he's a young comedian from Liverpool. He's very funny. And he started it from his kitchen table because he contemplated suicide and that, and now he helps loads of other people. So I've got some things, so it's like an app, you put it on and it's amazing.
Okay, so if you want to know more about it, you've got lots of little cards.
Yeah,
So that's a commercial breakover.
Selfless commercial
Oh,
breakover.
yes, absolutely.
Now, the other people in this group, please forgive me if I don't get it right. So we're just going through some of the other points.
Yeah.
I think
None of this is going to get lost.
No, exactly.
All of
So lots of other things, including sort of the big spud. I didn't think I really.
The big spud?
No one's getting tired. Sorry. So feel free to interrupt me. You know what I'm like. So and we talked briefly about the Women Who Self-Harm Network, or the Self-Harm Network, and then the person who is working on that, who is working with that network, has unfortunately had to leave now. But she was saying about that being a unique service, and services like that, not that there's many other services like that, depend on a small number of individuals doing everything, including washing the dishes and so on. And the perennial issue of uncertainty about future funding, and the funding landscape's always changing. We talked about personalised opportunities with navigators. I'm sorry, I'm sure it wasn't you that said about that.
I'm not recommending navigators. I'm just saying the system should be navigable and get personalised. If you need a navigator, you might be in trouble. It's system-wide.
Yeah, fair enough.
Okay. Okay, thank you. We talked about one of the difficulties in trying to understand what services are out there is about the big social differences as well as other differences across localities, for example, levels of deprivation and low incomes. And the person who's had to leave now was saying about the importance of a holistic approach
and services need to bear in mind things like access issues, that people might have a lot of other priorities like housing or debt advice or need for childcare or money for the bus fare, and not to forget how important all those other issues are, and there's more beyond. We talked about recovery colleges who are looking at skills that, some of them are looking at skills that can be taught shorter term, and then those skills might be people maintaining skills that they already have or learning new ones, and emotional literacy. I'm conscious these aren't necessarily specific to the main issues, but that's okay. And information sharing, which everybody kind of felt was very important, although it's fraught with problems, so that the professional and the person using the services can understand about the needs that the service might be trying to meet. Does that make sense? Okay. Then we talked about experts by experience. I'm sorry, was this here?
Yep.
Experts by experience sitting alongside psychologists, CCGs, and experts by occupation round the table. Yeah, oh, I'm sorry, I'm speaking on people's behalf, so I'm not. That was about a model that was supporting people to share ideas, of course, but we then moved on from that, to talk about peer support. We can talk quite a lot about different aspects of peer support, and particularly the importance of, if there are people involved in peer support, that there is support and supervision for peer supporters.
Yep.
And that's very important.
Yep.
But there are lots of other issues around peer support. So then we moved sideways, as it were, to talking about, this again was a person that left, who set up a book club, and she just put on Yahoo that there was a book club that people could come to in Edinburgh, and they could come along for a chat. She said that she said the downside of that was that the pressure was immense. She felt that people had expected her to be there once a month, and that wasn't always possible for her. And a much better way of doing it, which is now happening in, I'm sure, a number of places, is to have a rotating group of facilitators who themselves have support. Okay. Do you want to say something? No.
I think
you don't have
one
to
of
be
the
raw,
main things that we discussed that we haven't yet spoken about is about hope and purpose, and how it's important that services are thinking about outcome measures that actually matter, and that hope and purpose might be particularly important ones that we don't normally measure. I think all the rest of my scribbles basically duplicate yours in much less legible handwriting.
Anything else?
No. Yeah, just yes.
Yeah.
What did we say? We talked specifically about the need for culture-specific services. An example was given of an Asian women's group in Manchester, and of course there are lots of other examples. And something that and a need for outreach as well. That we can't expect people to come to services, and to outreach to particular communities. Something that I'm about to say, but I didn't know anything about, is that apparently Jewish community, people from the Jewish community, won't engage with a personality disorders diagnosis, if I got that right. So we were wondering whether models like teleconferencing might help there. Does that make sense? Yeah? Yeah, sorry. And then we also just finally, because I know I'm conscious of everybody else needs to speak as well, is DBT as being potentially a helpful element in community services, because it is one of the few types of treatment, I suppose, that has some evidence to back it up, but for people who want it or benefit from it, which is not everybody. I want about the relationship with the therapist, and not how important that is in all the circumstances, really, and it's very difficult to measure that, but we just forget how important it is.
Lots of evidence for that. Yes. You done?
We're all done.
Oh my God, we're all done in. I don't know about done. Oh, it's good to hear there's some diabolical behaviour therapy going on. Right, it's oh crikey, look at the time. It's 5 o'clock. It's very sad. I've got homes to go to. Thank you for that. Anybody got any final thoughts or questions? Good. I'd just like to say thank you for coming. Thank you for staying, those of you did, for all the naughty ones that have snuck off, they've got lives. Thanks to all the speakers and presenters. There's been a lot of information, information overload there. And obviously we've had the elf come out of the woodland to be here with us today, and he's smiling.
Doesn't snow in the woodland.
No, it was snowing earlier. Now he sensed that. That's an elf thing. He sensed it. And I said, don't tell them, they'll all bugger off home. But luckily it stopped. But it's a bit wet out there, so do take care going home. So thanks for everybody's efforts. Thanks for Kylie. I think Kylie has organised this. I think that she deserves a round of applause for trying to pull this together. And thanks to all of you for sort of pooling your expertise and knowledge, and also sharing some of the shitty bits of your life, let's put it like that. So, because it's not to illustrate your point. I think this is the start of obviously of a very important conversation. They're not going to lose any of the bits of paper with scribbles on. It's going to be put into the sort of greater, bigger conversation. But I just wanted to give Sonia the chance just to say something. You don't have to. You know, as much as I don't like to give a professor the last word.
No, no, I think just thank you very much, and it's time to go home, and well done for still being here. But I think the important thing is we will want to have a continuing discussion. We will have a big public event, which some people have been asking about once we've got more to say about this. And we will very much be looking to people for their further input.
Okay.
Thank you.
We'll hold you to that, Sonia.